for the board this morning. Can I also welcome Lowry Morgan, Dementia Programme Manager, and Rebecca Jones, Community Sister, and Anna Llewellyn, Care Group Nurse Director. The three are here to present the listening and learning story which relates to dementia in Cwmtaf Morgannwg. Great to welcome you to the board this morning. I think we are going to have to get a bigger room for our board meetings. Can I also welcome Dale Stolzenberg, who will be here for item 5.5. Dale's our Assistant Director of Transformation, and Dale is here to support our discussion of the development of the Maesteg Community Hospital site. Can I also welcome Daniel Price and Kerry Bear from Llais Cymru, who are sitting to my left, I said almost in the naughty corner, but great to welcome colleagues from Llais as always to our meetings. Can I also welcome Suzanne Rogers, Assistant Director of Digital Transformation, who is attending on behalf of Stuart Morris, and Dr. Sally Davis, our Deputy Medical Director, who is attending on behalf of Dom Herford this morning. So great to welcome you also to the board. Helen is joining us via Teams. Good morning, Helen. Good to see you. And can I just say, under item 1.2, we've received apologies for absence from Councillor Geraint Hopkins, Linda Thomas, Dom Herford, and Stuart Morris. Item 1.3, declarations of interest. I've not been notified of any declarations. Is there anything that anybody needs to add in respect of today's agenda? No? Okay, super. Item 2, the consent agenda. As always, and with a change to the agendas for our meetings, obviously the consent items are further on in our meeting, but are there any items on the consent agenda that colleagues would like brought forward into the substantive agenda? There's a few items in there, but I just wanted to check to see whether any discussion or debate was needed on anything specific. No? Colleagues are content? Okay, thank you. We'll note all those items when we get to them later on. Item 3, our shared listening and learning story. Absolutely delighted to have colleagues with us again this morning. You're very welcome to the board, and I know we've been looking forward to this discussion. A patient story in relation to dementia, a really tough area of our work as a health board. You know, something that really does, I think, demonstrate the best of our organisation. At that wonderful human level in what we do for people with dementia, but also what we do in supporting families as well. And I know that when we look at the data, for the next 10, 20 years, we will see a higher number of our population who will experience dementia, and therefore the impact not only on them and their families, but also I think certainly on our services and how we help to model the rights of service for the future. I think it's going to be really important. So a really important area of our work. So Anna, am I going to hand over to you first?
You are.
Yep, I'll hand over. Anna, thank you very much indeed.
Good morning, everyone. I'm Nurse Director for Mental Health, but I'm also the Chair of the Regional Partnership Board Dementia Steering Group. So I'm here with some colleagues today, Lowry, Programme Manager, and Rebecca, who's a nurse practitioner in the community. We're going to tell you Kerry's story, and Kerry is Rob's daughter, and Rob lives with dementia. Larry's going to tell the story. We're not going to pause after the story. We're going to then lead on to tell you a bit about some of the work that we're doing in the community to support people living with dementia, but also tell you a little bit about one of our work streams, the hospital charter work stream in the Dementia Steering Group as it relates to Rob's story. So I'll hand you over to Larry to tell you Kerry's story. Thank you. Go to the next slide, please. Sorry. And the next slide. There we go. Larry, over to you.
Thank you. I'm writing this on behalf of myself, Kerry, and my dad, Rob. The story starts when Dad was diagnosed with vascular dementia in 2017, aged 62. Dad managed reasonably well, still walking mountains, watching his grandson play rugby, pretending to be Percy Thrower in his glass house and being my mother's well-trained husband until October 2020. Dad contracted COVID-19 and was hospitalised for a month. Medical staff didn't think he would survive, but he recovered and against the odds thankfully came home. He quickly deteriorated and my mother followed fast behind him. At the beginning of January 2021, despite all of my best efforts to support my parents, my mother could no longer cope. I feared for both of their safety, and this is when Dad was admitted to Angels and Clinic. I cannot begin to express how much that day still haunts me. My dad going off to an unknown place to any of us, with unknown people. How could we explain any of this to him? When would we be able to see him again? Trying to get Dad ready was the hardest thing I've ever done. Dad had an accident, so I was trying to get him dressed. Dad had other ideas. I tried my best, but he got so flustered that he proceeded to headbutt me. I had to ask my husband to help, as he was very upset with me. There were so many fears and uncertainties. Dad knew exactly who Dr. Chan was. He liked him, so I explained he would be going to see him and his nurses. Dad was delighted. Dad walked into Angelton a happy man, going for a cuppa and some biscuits with the nice nurse, Dr. Chan's nurse. We decided to not arrange any visits because we didn't want to unsettle him. I rang every evening to check in how he was. I took things down, but for 3 weeks we didn't see him. A nurse, I think his name was Liam, asked me to give it a go and that it would be good for Dad. We visited and it was awful. COVID meant that we had to wear masks, gloves, aprons and couldn't go within 2 feet. Dad cried at seeing us. When the lady showed him videos of his grandchildren talking to him, he cried saying, "They love me, don't they?" This type of visit happened every time we were allowed to see him. COVID had so much to answer for. The time came for Dad to move out to a care home, or EMI unit as it's referred to. My dad wasn't elderly at all, but my mother couldn't care for him at home. I had no choice but to help find the perfect home, the home where we could help him feel safe, secure, and we could help the staff look after him, his forever home until dementia had taken him. We found what we thought was the perfect place. Several meetings occurred and the date was set for him to move. We were quite excited at the time, thought of Dad being settled and at home, although it was bittersweet, as we had to leave the place he had called home for almost 5 months, with people who knew him and his needs so well. I don't think I'll ever forget Kath, the sister at Angelton. I wanted to go with Dad to settle him in the new home, but due to the COVID restrictions, the home wouldn't agree to this. I spoke with Kath, explaining that he would be going to a place where he didn't know the environment or people, and I was really upset by that. He would be going in an ambulance on his own with all his belongings. It felt so wrong. Kath listened and arranged for her to travel with him. I will always be grateful to her for that. She said he loved the ride. It felt like we had abandoned him at a time when he needed us most, but with Kath's help, we felt like he was safely handed over to his forever home, nestled in the mountains, one of his favourite places. Unfortunately, it wasn't meant to be. Dad was treated terribly, suffering physical abuse from a member of staff. I received a call to go and pick him up as there was a bed in Angelton waiting for him. This was the first we knew he was being served notice. His behaviour was unmanageable. I corrected him and he was a very cheerful man being in the car with me. I hadn't been able to touch him since January and this was July, so I sat outside Angelton Clinic with him in the car. I was in no rush to hand him over. I FaceTimed my mother and after an hour I walked him into Angelton. The reception he had was just the best. I forget his name, a tall healthcare assistant, looked at Dad and said, "Well, Mr. Bevan, it's lovely to see you again." My dad's face lit up and was so pleased to see him. It was like he was back home. The sense of relief was undeniable. Finally, Dad was safe back at Angelton. We FaceTime and visited every week. The staff yet again cared for Dad in the best possible way. Dad was settled and happy. Nothing was ever too much trouble. When we went back into lockdown, I used to see Dad through the window. I would take him to Starbucks and drop it off. My grandfather, Dad's father, was terminally ill and they hadn't seen each other for close to a year. My grandfather was 94 and it would have been impossible to get into the hospital. So I asked Mel, the ward sister, if I could pick Dad up to see his dad one last time. Mel worked with me and made this possible. This made it possible for them to be reunited one last time. It was absolutely wonderful. I will never forget them telling each other they loved each other. Months passed and Dad continued to thrive at Angelton. One particular staff member that would always stand out was Sharon. She had such a fantastic rapport with Dad. I'd ring up and she'd get him to come to the phone to talk to me, always making sure she passed on the positives. Early in 2022, it was mentioned that it was time for Dad to move again. With hesitation, we agreed and found another care home. After a few had turned him down, we felt this home was more suited to Dad due to his being only 16-bed dementia specialist. In April 2022, a day before he was due to move out, we organised a tea party for the people living in Angelton and the staff, just as a thank you, although we knew we would never be able to thank them for the care they had shown Dad and how safe they kept him. Once again, early August, I received a phone call from the community mental health nurse telling me that Dad needed to go into Angelton, as the home was serving notice on him. I was devastated. It took all our optimism to allow him to go into the home after the previous failed placement, and here we were again. How could these so-called specialist dementia services actually be claiming they were specialist? They had failed him. But yet again, Angel Clinic came to the rescue. He walked in there and Mel met us. He was as pleased to see her as she was him, and happily went with her. Again, we were able to breathe a sigh of relief. He was safe, with people who understood him. Unfortunately, the next day he took a fall and broke his hip. Nothing more than an accident. He was in the garden, the great outdoors, and fell. I remember the call I received and how apologetic the staff were. Absolutely no need. It was an accident, and we trusted no one more than the angels at Angleton Clinic. After Dad was discharged from hospital back to Angleton, he began rehabilitation with the physios and occupational therapists. Unfortunately, this wasn't as effective as they had hoped, and Dad became immobile. We went through some difficult times at that point. Unbeknown to Dad, my sister's husband died of a brain tumour. We knew that we could trust the staff to take care of Dad, and he was safe whilst we spent time supporting my sister in England. Without that peace of mind, we could never have looked after my sister and niece. At the beginning of 2023, Dad was medically fit for discharge. We were in this listing again. We couldn't believe it. Were we really in this position again? Hadn't Dad been through enough? We decided at that point that it was in Dad's best interest for him to remain at Angleton Clinic, but also realised that this would probably mean having to go to the Court of Protection for them to ultimately decide. Our wish was that Dad wouldn't survive as long as that process took, as we would rather lose him than move him out of where he knew to be home. Several meetings were held. They were hard, and we realised Angleton was a hospital, not a long-term care facility. However, how could we not do everything in our power to keep him there? The only place he was safe and the only place that wouldn't evict him. At the advanced stage of dementia, he deserved that right, surely. We then decided that if we couldn't stay there, the only other place he could go was home. This was agreed, and we welcomed Dad home in November 2023. Since Dad has been home, he has settled and has continued to swear at anyone that could even dare think about helping him with personal care. Dad's communication is not recognisable now, but the swear words are as plain as day. The staff in Angleton will always hold a special place in our lives. At our very darkest moment throughout Dad's journey, they've never let him down, never failed to welcome him with a warm, trusting smile, make him feel that he's understood and safe. For us as a family, they've enabled us to sleep at night knowing he was safe, cared for, and with staff who understood. I will never be able to show my gratitude to the staff or express the positive impact they've had on the most difficult of times.
Thank you, Larry. We are going to move on. I'm conscious it's quite emotional. So we could go to the next slide, please. So I'm going to hand over to Rebecca, who's going to tell you a little bit about how she is supporting people living with dementia in the community.
Thank you, Anna. So as a district nursing service,
Just the next slide.
Oh,
I'm sorry. And the next slide as well. Sorry, Rebecca.
that's okay.
You carry on.
Okay. So as a district nursing service, we are seeing increasing numbers of people just like Rob living with dementia. These individuals come onto our caseload, not necessarily because of their dementia diagnosis, but usually for other interventions such as catheter care, wound care, or pressure ulcer management. As a district nursing team, it is imperative from the first visit that we are holistically assessing the patient and their medical history, taking note of anything that may cause pain alongside the general aging pain that we all experience. There is a misconception that dementia diminishes the experience of pain, whereas in fact it is the ability to verbalise or communicate the pain that is impaired. We are taught as student nurses that pain is what the patient says it is, but through experience, I now understand that our assessment must delve deeper than simply asking someone living with dementia if they are in pain. Pain manifests itself in many different ways and is wholly subjective to assess, and also very much depends on the nurse's experience. What I do continually experience personally, however, is significant behaviour changes, which are then attributed to an exacerbation of their dementia rather than being driven by pain. I instill in my team that if it was to cause us pain, it will still cause pain for the person living with dementia. It is essential that as district nurses, we are building strong and trusting relationships with our patients like Rob and their families and care partners like Rob's daughter, listening to what we are being told, but understanding that there is much to be interpreted from what we are seeing when we are assessing our patients living with dementia. It is important we understand how the person we are caring for may show signs of pain at a time when they may no longer be able to reliably verbally report that pain. Many common symptoms include grimacing, frowning, verbal or physical aggression, guarding, pacing, hallucinations, inconsolability, resistance to care, inactivity or withdrawal, and challenging behaviour. These are usually treated with antipsychotic medication as the behaviour is seen to be so significantly altered, when in reality it's possible that paracetamol would actually suffice. Deciphering the difference between pain behaviours and dementia progression is extremely difficult, but for dignity's sake, we must do better at assessing and managing pain in those living with dementia. Dementia is a physical, chronic condition rather than a mental health illness. Therefore, more training and development is required as part in respect of managing pain, as the numbers are growing exponentially year on year. Every other chronic condition has a specialist nurse directing appropriate care and providing well-being support to the patient and families. But there is a gap in this service provided for people living with dementia. And having a specialist nurse for people living with dementia will ensure appropriate training is given to staff, patients are advocated for, and are receiving the best possible care.
Thank you. Thanks, Rebecca. Please, the next slide, please. And the next slide. I'm going to hand over to Lowry, who's going to talk just very briefly about the hospital charter workstream that is in the RPB Dementia Steering Group.
Thank you, Anna. So anyone who knows me knows I'm not very good at talking briefly about the dementia care pathway standards, but I will endeavour to do this very quickly. So what I wanted to just draw our attention back to in terms of the story that we heard, Rob and Kerry's story, was the feeling that they had, how they felt about Angleton, how they felt about the staff, how they felt about the environment, and how positive that experience was. I think we can all agree that that isn't always the case for all of the people who come and reside with us. So as part of the work that we're doing to implement the All Wales Dementia Care Pathway of Standards, we're looking at our hospital environments. And the improvement work that we're endeavouring to do across our health sites isn't just about the physical environment, it's also about the culture and the care that is provided. And I wanted to highlight some good practice examples that have already happened in our health board area, and just moderate that with that this is a work in progress and that it will take some time for us to deliver on all of our, I suppose, our vision about creating these dementia-friendly hospital environments. So what I'm highlighting today, one of the things I'm highlighting today is some of the work that's happened in Prince Charles Hospital. So within their emergency department, they have installed better dementia-friendly signage. They've got a cubicle within the emergency department which can be transformed into a living room. So they've got a screen that they can pull down that makes it look like a living room, and they use the Rita systems, which are interactive tablets and tables to help to work with people with dementia, to calm, to distract, amongst other things. Within Ward 3, which is our older adults ward in Prince Charles Hospital, they've done a number of things to improve their environment. So they have regular therapy dogs, and I will show you a photo of one of them later for all the dog lovers around board today. They redeveloped one of their storage rooms into an activity space in the salon. They've installed a bus stop. I know this sounds really random, but for some of our patients who are expressing that they want to go home all the time, they can go and they can sit at the bus stop. And a nurse or a HCA can say to them, "Oh, I'm sorry, Mr. Jones, you've missed the bus. Let's go and have a cup of tea while we wait for the next one to come." Sounds really simple, doesn't it? But actually it can make a really big difference. They've made connections to charities for crafts and activities and created activity trolleys so they can engage people in meaningful activity during the day. And they've established a task and finish group between the emergency department and their ward so that they can improve the transition from our accident emergency departments at the front door so that it can be the best that it can be. And I'm not saying that it's always the best that it can be, but that this is the endeavour to make it the best that they can possibly make it. Next slide, please. And here's some examples of what Ward 3 looks like. So they've installed fidget boards on the wall, there's the bus stop, they've put some decals on the windows, so where some of the windows are overlooking less than ideal scenery. They put some stickers on the windows so that people can have something to engage with. There's an example of one of the screens that can be pulled down to make a room look like more like a kitchen. And right in the corner, you can see one of the therapy dogs that attends regularly. Next slide, please. Some other work that we've been doing across some of our sites, we've been looking at the King's Fund audit, which is a tool that we use to audit our environments to see whether they're dementia friendly or not. And we actually did this in co-production with people with dementia and their carers and people with lived experience. So we used an adapted version of the King's Fund audit tool in Ysbyty Cwm Cynnan in our Health and Wellbeing Centre. And we use this collaborative approach to assess the environment. Next slide, please. And you can see this is what the environment did look like. And what people told us was it was too hospital looking, it was cold, it was clinical. Is this the type of environment where you want to receive your dementia diagnosis, which can be which is traumatic for families and for individuals. Next slide, please. So what we did is we commissioned some really bright and colourful artwork that was representative of the area so that people could engage with that. We've created more homely outside spaces to promote wellbeing. And one of our quotes there is that the artwork's been really well received by the patients attending the clinics. The detailed colour and general theme of each painting has provoked positive feelings for our patients. And what we're doing with the King's Fund audit moving forward is we're seeking to embed it into the regular audit process amongst all of our wards, so that King's Fund audit will be undertaken across the site. Next slide, please. Some further work that we're doing under hospital charters, we're looking at things like, has my care been good enough? We're using robotic pets and hugs. We've got Wellbeing Wednesdays to support staff. Patients are involved in bedroom door signs on admission, and they have a what matters to me conversations. And we're doing a This Is Me monthly audit of assurance. So for anyone who doesn't know, This Is Me is a biographical tool that helps to outline people's likes, dislikes, what works well for them when they're upset, what works well to calm them down. And what our hope is that rather than this just being a document that people fill in and nobody looks at, that we actively use it in the care of our patients. And we've also implemented logins for everyone across the health board for our KFit for VIPs platform. The KFit for VIPs is an online platform, and what VIP stands for, and I always forget what it means, so I wrote it down this time. V is for values people. I is for individuals' needs, P is perspective of the service user, and S is supportive social psychology. And basically what it is an online improvement platform. So wards can upload their improvement projects onto the KFit for VIPs platform, because quite often what happens is we do good things, we don't put it anywhere, we don't talk about it, we don't record it, so then we can't spread the good practice because it becomes really isolated. So what we're doing with that KFit for VIPs platform is ensuring that we're able to review, discover and transform our services, as it says there. Next slide, please. Okay. Difficulties. Oh, there we go. So just very briefly before we move on to the end of this presentation, there is a link on the slides to a song that we co-produced with people with lived experience as part of our hackathons that we run under the Regional Partnership Board, called Life is a Journey. We won't play it today because I understand there's been technical difficulties in the past with playing videos and songs, so we won't play it today, but it's there for anyone to listen to, as are our contact details. And that final link on the slide, it takes you to our RPB website, where if anyone's interested in being involved in the dementia work, you can sign up to the programme and receive updates from us. Or again, if anyone wants to find out more, as any further questions that they want to ask after this meeting, our email addresses are there for you to contact us. Thank you.
Thanks both. And we're going to end there. Really grateful for the opportunity to tell Kerry and Rob's story today, and I hope that some of the work that we're doing through the Dementia Steering Group and in the community highlights that we're really trying to improve the experience of people living with dementia.
Thanks, Anna. And before I throw into questions, I'll come to Sally first. Could you pass on the thanks of the entire board, please, to Kerry and for sharing the story, because it's extremely powerful explanation as to the experience, not just of Rob, but of Kerry and family. You know, I know we don't forget this, but obviously, as I said earlier in the introduction, dementia has a huge impact on not just the individual, but on the family, the friends, and of course, and the staff as well, because the staff very often, you know, form a very strong relationship with a patient who is, you know, very often with us for a significant period of time. So please pass on all of our thanks. I think it was you know, quite a very emotional story, but it was good for the board to hear it. Sally, I'll come to you first.
Yes, also echo that thanks, and that was a very powerful story and highlighted, you know, some of the very many difficulties families and patients have with dementia. Fantastic to hear what you're doing, and all the good work. And of course, with our aging population, as you pointed out, this is going to be more and more of an issue for all our most of our specialties across all the sites. So really good to hear what you're doing, and look forward to working with you to continue that work. Thank you.
Great.
Larry, you read the story beautifully. I have to say it was really powerful, really empathetic, which is great, and the work is fantastic. But I have to say to Rebecca, awesome. And Rebecca actually has had her work published nationally in relation to some of the work. I had to get that in, Rebecca, because it's on the record. It's on the public record. And I guess my question was around the work that you've done in PCH is great. The kind of the spread and scale bit, really. And I know it's part of the hospital charter, but just maybe a couple of responses in relation to spread and scale.
Shall I answer that? So Rob Richards is the workstream lead for hospital charter. He couldn't be here today, but we have champions from every single hospital across the health board, and it's their role to take that work forward across the health board. But it is hearts and minds stuff. It is about passion. So the work that's happened at Prince Charles is because those champions really engaged and got excited by the work, and actually seeing the difference that a bus stop might make, it then translates to the wider work streams.
Dennis?
Yeah, I'd just like to say that Dom and myself to walk around the ward 3 BCH, and everything that's been said about it this morning is absolutely true. The staff are absolutely amazing in the care of their patients. What wasn't mentioned this morning is that one of the dogs actually belongs to a member of staff who had the dog trained, and who, whenever she's taken the dog into the ward, has the dog washed and brushed and groomed so that there's no chance of taking any germs, etc., into the patients. So that's how much the staff on that ward care for those patients. I just wanted to make sure the board was aware of that as well.
Thanks, Dennis. That's very helpful. Catherine?
Yeah, thank you. Really moving story. So thank you for sharing it on behalf of the family. I suppose the bit for me is how do we that transition from Angel or from one of our other older adult environments into nursing or residential care is a really important transition. And clearly for this poor chap, that didn't go well on 2 occasions. I suppose the question that we probably need to consider is what more can we do to support that transition, recognizing it is always a challenge, and that first few weeks is always really difficult, even if you're going to a home that is specialist, and I guess there's something about what can we do from an intensive support to really try and help that transition so that we don't have experiences. There will always be challenges, but it's what more can we do, I guess, is the question that ran in my head.
Yeah, thanks, Gavin. So definitely one of the things that we can do in terms of strategic planning for the future is the development of care home in reach provision. It's early days, but we're having some early conversations about our older adult mental health redesign, and that's something that we have a potential eye to the future on developing, because it is obviously really important to make sure that there isn't placement breakdown. And I will say that the staff at Angel Turn worked very closely with Kerry, and he has significant needs, and the placement in his own home was a bit of an experiment. Many of the staff and indeed Kerry weren't quite sure if it would work out, but he is supported at home by a range of agencies. So it's working collaboratively, I think.
Thanks, Catherine. I'm just thinking, I'm looking at Lisa at the end of the table, just Lisa with your hat on as a director of social services in Merthyr Tydfil. But if we're looking at what that collaborative approach could be, and looking at what the capacity and needs are likely to be going forward, and reflecting on Anna's point around thinking about the model of our older adult services, particularly in mental health, what those care needs are going to grow, I suppose, aren't they? If you think about the range of needs of people with dementia, there's the health input, but also there's the social care input. And I'm just wondering what in terms of your analysis and the data that you tend to look at with other social services directors, what the picture is looking like and what we should be doing about it.
Going on Gettin's question, I was going to ask the same sort of thing. I suppose mine with more negative sort of context to it. Really emotive story. I mean, it breaks your heart that people are suffering in that way. Such a cruel disease. And I've got loved ones who've had dementia, and I was sat here thinking, oh, don't cry, but it was really emotive. And thank you to Kerry and Rob for sharing the story. I think in children's services, if placements break down, we look at it and we look at lessons learned. I think we need to do the same with adults. So I mean, maybe something, an action to take away from board. Looking at Rob's story. Why did the placements break down? Is there something we could have done at different stages to prevent that breakdown? Because that would have made a whole difference to his journey. And I don't think we do enough of that in adult services. I obviously can only speak for Merthyr, but it is a gap. So I do think that that's probably something we need to think about, and I'm happy to sort of take that as an action aside to speak to the other directors and perhaps us look at that with adult services heads.
Any other sorry, Patty?
Yeah, just one question following on from Gethin's point really, and it affects dementia wards, but it also affects all other wards in the hospital. And it's about, difficult question, and I'm not pointing blame anywhere, but how honest are we with the care home or whatever other facility the patients are going into about the condition of the patients? Because there is clearly pressure on the bed base. There is clearly a need to move patients into a suitable alternative outside of the hospital site. And I wonder just, how honest, there's no other way of putting it, we are about the patient's condition. Because if we underplay it, and I've seen this in my own life, then the care home isn't capable or suitable for that particular patient. And once it solves one problem on one day, it just creates many more problems down the line.
That's a really important question. I think, Lisa, do you want to reflect on that?
Just to reflect on that, from a social services point of view, I think health are very honest about the sort of conditions when people are discharged from hospital. There is pressure, don't get me wrong, so if we can find a placement today, then obviously that's what we'd look at. But, most of the time a manager or a senior member of staff goes to the hospital to part of the assessment, so they see the patient before they're placed. So that is part of the assessment. So there isn't any way you can hide, sort of any sort of concerns. So, there's a referral form. Sometimes the quality of those are different, but obviously that visit to the hospital to see the patient makes a real difference.
Thanks. Anna?
Can I just come back, just to reiterate what Lisa said? It's full transparency. That all care homes come and assess patients face to face, and they also access all of the records when they do that. I think perhaps what sometimes happens is that people living with dementia, maybe in one context and then in another context with different environments and different relationships, can impact on behaviours that challenge, etc. So very, very honest is what I would say people are. There's full transparency.
And I think the boards are really good at knowing what homes are best suited for, particularly for patients such as Rob, where they know there's a particular need. They know those homes well, and they will be going, actually, that's probably the better home. So they, the ward staff don't want a position where their patients come back in the way that Rob came back. And I think they do really try to help choose the right home with the family.
That's it. Laura?
Yeah, and just building on what Anna was saying in terms of the differences in the environments. So clearly in an inpatient setting, we've got that full MDT, haven't we? So I think there's something about the competencies that we support people with outside of that setting. The impact that that has when that full MDT isn't around.
I mean, just me to sort of bring it back. I mean, really powerful story, and I guess a few reflections from me. We know, I think, Gethin, don't we, that a diagnosis of dementia, when we look at our length of stay data in hospital, adds a significant amount of time to that. Now, part of that is just the complexity of the individual, but it's also about trying to find the onward care for that person. So I think there is something about how, and I know Lisa and colleagues in other social service departments and Linda and others are looking at this as part of the RPB sort of commissioning plans, because we know that our capacity from the independent sector for these sorts of patients is quite challenged. We don't have huge amounts, but yet we've heard today there's a huge growth projection in this space. So we need to collectively think about what are we doing together, not just social services, not just health, but together to make sure that we've got the right capacity, both for residential types, but also home-based support as well. Because obviously for these people, if we can try and keep their home for as long as possible, that's the best setting because it's familiar to them and it helps manage that. So I do think there is a strategic question for us as a system about how we're making sure that we've got enough good quality provision in the future. But that, as we've said earlier, we don't see that as we've learned to patient in the independent sector and that's it. We've got to collectively work together to support those individuals, whether it's about in-reaching, using the professionals that we've got as experts to go and support the care homes, providing ongoing opportunities for the care homes to pick up the phone to a specialist nurse and say, oh, I'm not quite sure about this. Could we get an OT to come and do a bit of work with us on this if we haven't got that capacity in-house? So I think we've got to think a bit more laterally about how we sort of develop those sorts of pathways. And the other point I was going to make was, talked a lot here about the dedicated provision for patients with dementia, but of course those patients are coming in to radiology, they're going to outpatients, they're going into GP practices, they're going to all of our other facilities. So there is also something for us, not just about how we redesign and get better at our spaces for dementia patients when they're inpatients, but you know, we're talking about developing the Trust and Health part and the diagnostic. Well, how are we making sure that when we're designing a diagnostic centre in the future, that it's going to be fit for scanning people with dementia, because that is a really intimidating thing for someone with dementia to go through, to go and have a CT scan, for example. So what could we be doing to think about how we bring some of the great work you've done on some of our EDs and inpatient wards into other parts of our hospital when we're looking at refitting and refurbing facilities? Sorry.
I'm sorry. Just to reiterate what you said, I think, as I said previously, there really is a gap in the service that we're providing to these patients living in the community, and that are being transferred from secondary care.
Yeah.
And I think by stemming that with a specialist nurse, which is the only chronic condition that doesn't have, and I know I do get my soapbox about this, but I think it is really something that perhaps the health board needs to consider, because I'm wondering then if there's more of a liaison service between the secondary and primary care, whether we would have these situations of people being given notice in care homes, bouncing in and out of hospital. Care could be better facilitated. So for me, that's where I think we could really improve.
Brilliant.
Okay, and I think as a board, it would be, you know, based on that, it would be wise for us to consider, look, as we're planning for the future, you know, what are our gaps? There's one gap, okay. How can we address that? What will it take in terms of resource and recruitment? And what would it need to deliver that? So I think we've got to think about that as we start to plan our services. And yeah, we will be, as we already have started, conversations and discussions about the development of the acute clinical services plan. We know what the picture of dementia is likely to look like in the next 10, 20, even 30 years. So as we have a longer term view as to what we do on our hospital sites, across all our hospital sites, what sort of capacity are we likely to need to support potentially increased number of people who may require hospitalization at some point. So you know, all of that, I know we will be thinking about all of that, but obviously what we have now presumably will be sufficient maybe in 10 years time, and I think we have to Linda.
Yeah, and the need to be really clear about why people need a bed, because I didn't hear what so part of the work we need to do is be really clear about the end-to-end pathway. I wasn't clear why Hendrickson was the solution in the first place at the beginning of his journey. We've got the gift, haven't we, to turn that around, but only if we are a bit more willing to not be a repository and use our beds in a way that actually basically rescues the rest of the system. We need to turn the system on its head.
Yeah, absolutely. Yeah. Sorry, Nicola and then Ian. Yeah.
Thank you, Chair. We hear lots of patient stories at board. What we very rarely hear is further down the line, what we have done in regards to the lessons we've learned from the patient stories. So I think it would be really helpful in the future if we have another discussion on what we've done, what we are going to do in relation to some of the concerns that have been raised by this family, so that we are sure that we are closing the loop, because there's no point in just listening to a story and saying, how emotive, how emotional, how we're all touched by it, if we're not there going to do something about it.
Agreed. Ian?
Yeah, Jonathan, you're on about the potential gaps maybe we have in the service. One of my point is do we have equality across the different regions we're dealing with, from Bridgend, Merthyr, Rhondda, Llantrist and so on? Or is the same service we've just been described, is that the same across everywhere?
Anna, sorry.
Thank you. So in terms of Linda's point, just want to reiterate that Ron had significant complex dementia, and he came into Angelson. So Angelson is an assessment centre led by mental health practitioners, and because of his complex needs, he had significant behaviours that challenge that are difficult for other providers to support. So that was the reason he came into Angelson. In terms of the equity of provision, one of the things that we've done through the Dementia Steering Group is commissioned an external agency to look at that for us. There is some resource, regional partnership resource, that is linked to dementia, and we're using that to assess that very point in terms of equity. Don't quite have all of the answers yet because we haven't completed that work, but we will do soon, and it will be reported then up to the RPB.
Thanks, Anna. Just reflecting on Nicola's point around actions that need to take place following the consideration that we give to a patient story. I think, Anna, would you be able to pull together some of the key actions coming out of this discussion? I'm conscious that around staffing gaps in particular, we think there are things that could be done in the future that will make a difference, along with other areas for us to consider, and then perhaps we can bring a paper back to board for us to work through and to agree if there are specific actions that we can sign up to further develop our services. So I think that is absolutely the right approach. Notwithstanding the fact, I think there are things that the RPB needs to be clearly involved with, and both Lisa, Linda, and I, and others sit on the RPB. There is a broader, planning. The importance of that sort of wider planning function within our community-based care that the RPB clearly is also involved, and I think we have to consider that along with the commissioning responsibility of social care. But this is an area for us where we are going to see significant growth. We can't just say, oh well, I'm sure it'll all be fine and we'll just wish for the best. I think we've got a plan. We've got a plan for the future. So I think some key actions, and it will be terrific.
Yeah.
And I think to give the board something to agree to. Yeah. Okay.
Thank you.
Thank you very much indeed. That was superb, and I really appreciate your time this morning. Thanks. Thank you. Okay, we'll move on to item 4. So item 4.1 is my report as chair. A couple of items that I've covered off in the report. There is also just to notify the board and to ask for approval around the fixing of the common seal in respect of one item. And of course, there was the chair's urgent action taken recently as well. I noticed one item has been covered in Paul's report as chief exec, but I again, whilst I've mentioned it in my report, I just want to state publicly my thanks to all of our staff right throughout the organisation for the work that's been done to support the significant improvement in our maternity and neonatal services. The Cabinet Secretary for Health and Social Care agreed with the recommendation to de-escalate those services, and that I know has been a long time coming. It's involved a huge amount of hard graft, but the level of confidence now that you see in the delivery of those services is a very high level, and I'm absolutely delighted that we have had that decision by the Cabinet Secretary. Likewise, of course, with our quality governance, leadership, culture, trust and confidence, something that we as an organisation have worked on, again, with significant pace and now to great effect, that the Health Minister has decided to de-escalate us in those areas as well of those are very important matters, of course, for us as a health board. So my thanks, not just to Greg and to Suzanne, but to all of our teams for delivering what has been a tremendous result. I have flagged in my report my concern and perhaps growing frustration at the challenges, perhaps the failures. I use the word failure; it's a strong word, across our health and care system that sees too many people ending up in hospital who could, quite frankly, be looked after closer to home. And if those needs were provided to closer to home, probably wouldn't end up in hospital at all. And the challenges we face in people being able to leave hospital when they are medically fit to do so. I think this is getting to a point of crisis. 2 weeks ago, Paul and I met with Dawn Bowden, the Minister for Social Care. I think there will be there's going to be a further piece of work done by ministers in Welsh Government now about the sorts of things that health boards and local authorities need to be doing to address this. I did say to the Minister that we were doing a significant piece of work here in CTM through Matt Jenkins, our Regional Director, looking at the development of a partnership agreement. Section 33 of the Social Services Act is not really being used by any region in Wales to try and formalise a partnership arrangement where those resources, strategic and operational, can be brought into one place to make better use of the strategic thinking, but also the money that we are spending in supporting people throughout our health and care system. And I think that it will be not just good for patients and their families, which is the important bit, but good for the efficiency and effectiveness of our services if we can get our partner organisations together collectively here in CTM into a place where we are able to be more effective in helping people to receive the health care and support they need at the right point. And I think that is something that has been raised on the political agenda. The Minister, the Cabinet Secretary for Health and Social Care, raised it with the 7 health board chairs the week before last. I suspect this will be a very hot topic over the next couple of months, but there's pressure on us. I think there will be a lot of pressure on local government as well. And I think this just puts us in a place where we can advance our agenda in CTM, but also perhaps offer as a model to other regions of Wales who are thinking about what to do next. But it's a really important area of work, and I just wanted to flag that up. So just to ask colleagues, if there are no questions on my report, if colleagues will be willing just to note the chair's report, but to endorse the affixing of the common seal and to approve the chair's urgent action as set out in the report. Are colleagues content? Yeah. Okay. Thank you very much. Just moving on to the action log from the previous health board meeting. There are a couple of items there that are still in progress. One or two that are due to be delivered, or one was due to be delivered by the end of March, and there are some that are due to be delivered by the end of this week. I don't know if there are any updates on those items, Gareth?
Yeah, can I just talk about the first one, the Audit Wales and Healthcare Inspectorate Wales joint follow-up review into quality governance. So that information was actually submitted to Audit Wales colleagues on the 15th of April. I received an update from Dave Thomas on the 13th of May that acknowledging receipt of all that information. Both Audit Wales and Healthcare Inspectorate Wales are working through that information now. I'm hoping to come to a conclusion by the end of this month. Obviously, 30th of May today, I haven't heard anything as yet, but I think that should hopefully be closed off imminently.
Okay, thank you. Any other updates on the action log? There are some things that are due to be concluded quite soon. So, okay, unless any questions from colleagues, I'll move on to the Chief Exec's report. Thank you, Paul.
Thanks, Chair. Just to reiterate, as the Chair said, obviously really good news about our de-escalation, and again, just add my thanks to everybody's for the hard work that's gone on to get to that point. Interesting, yesterday again, Greg and I were asked by Betsy to join one of their executive meetings to tell them a bit of our journey that we've been on, because obviously they are going through some similar challenges up there, and it was really helpful and actually interesting, very big parallels from what they're trying to manage at the moment with where we've been. So it was really nice to be able to share some of the positive improvement work that's gone on, both from a maternity and neonatal perspective, but also on the wider quality governance process. So yeah, really, really positive. Obviously, we are still escalated in planning and finance and performance, and those are being monitored through arrangements with Welsh Government. So we will wait and see. Hopefully, as those things improve, that will also potentially de-escalate further. Just also to give an update, the IMDP went in at the end of March, and thank you to everybody for the hard work that went into putting in the IMDP. We had some initial feedback, which was quite high level, really, from Welsh Government about the plan, particularly around the choices we've made. And I letter went back yesterday to Welsh Government just on a couple of the outstanding questions they had. I wouldn't anticipate that there's going to be a problem with them approving the plan, given where we submitted with financial balance. Just to highlight that we were the only house board that did submit a plan for this year with financial balance. So in terms of an approvable IMTP from a financial perspective, it should be approvable. And we've got a review meeting in a couple of weeks' time, I think, with Welsh Government to just go through that process with them. Just on the, in fact, back to Nicola's point earlier about the patient story from the last board meeting, where we had that patient story relating to the gentleman who'd been in Princess of Wales, who'd been quite considerably, well, there's a range of things, both in terms of the care he received while at POW, but also his transfer and delays around that. We, as a consequence of that, I got a small group together of, including Adam, who was the nurse practitioner that came and gave our patient story at the last board meeting about a few weeks ago, to just talk about, from a health perspective, what more could we be doing potentially to support people to be discharged earlier, recognising for many of these people getting home is really, really important, and often it's potentially some of our services that aren't available in the community that are preventing that from happening. So we've got a little task group that we've established, and we're going to call it, in fact, colleagues don't know this, we're going to call it, Adam and I have been talking, we're going to call it after the gentleman so he's called Verdon, so we're going to call it Project Verdon, because I thought it's really important to remind ourselves what has made us sort of take some action on this front. So so Adam and colleagues were really helpful. We had therapy colleagues, district nursing colleagues, GPs, all sorts of different people, care delegates, physicians from the hospital, and a real willingness actually to think about creatively how can we use our resources in a different way to try and get some of these people home with support from our community teams. So I'm hopeful that by July we're going to be able to bring an update back to board on some of the thinking that the frontline teams have had around how we can do something different around that, because I think we all recognise that what we've heard at the last patient story, what any of us would want for our relatives. So really positive, actually. I'm really engaging from our clinical teams on how to do that, and some interesting feedback actually, even just in terms of risk and managing risk. That was one of the key things that came out from it, was actually staff's perhaps reticence about discharging people because they worry about what if something goes wrong, or what if somebody has a fall, because at the same time we're busy bringing people to account for why people have fallen over, and they were saying, well, actually sometimes you are going to have people falling because we're taking a little bit more risk about letting people do things for themselves. So it was an interesting point, not just about the service models that we could develop, but also the sort of culture and the governance processes we put in place to oversee that, to make sure it's safe, but that the safety doesn't become the overarching ambition, rather than enabling people to do what they need to do. So really positive story from that. Also, just to say, we'll be bringing something back here. Matt's been working on this with the exec colleagues, just to sort of give some I'm conscious there's a lot of things, there are a lot of things going on at the moment across the organisation in all sorts of different spaces, and sometimes it's difficult to see all the key strategic projects in one place. So Matt is putting together for each of the directors the key strategic priorities for this year, and we're going to have some sort of a tracker that we will develop so that the board will be able to see on a routine basis, these are the key things that are happening this year, and you'll be able to sort of anticipate when you should be seeing things. So the conversation we just had this morning about the diagnostic centre is just one of many things. So that will be coming back to you in the future. And also just to say really positively, one of the nice things I get to do every month now is to go around and present the 7 of the Month award. And you'll know the 7 awards are our staff recognition awards, which are peer nominated. So these are members of staff who nominate their colleagues for recognition. And every month we select through a process of involving a number of people, a 7 of the Month winner. And it's been great to be going around to meet with these award winners, and you'll see from the list there, it's a really diverse range of people who are being nominated and are winning. So both in terms of their role, their location, hospital services, community services, mental health services, but also some of our services perhaps don't get so much profile. So things like the mortuary, which I know Kath and Stu did a bit of talk about to yesterday, but you know, often they're services that are working away really hard behind the scenes that people don't see. And what was really nice in that bit was, you know, Yvonne, who got the award, was saying, oh, we don't normally get any recognition in mortuary services, and they really appreciate it, not just for her, but for her whole team. It was a really nice way of their service being recognised. And last week I went up to PCH and met Paul, who was a pharmacy tech, and it was really, I was saying to Howell, a really great story. So local person from Merthyr, did his A-levels, didn't know what he wanted to do. In true PCH style, his mum worked in the pharmacy. So she said, oh, why didn't you get a job in the pharmacy? So he's come and worked in the pharmacy with his mum, but he's been trained up to take clinics that previously were being done by pharmacists. So he's been supervised. He now runs clinics for people with heart failure, helping advise these people who've had medication changes post their event. And he's now doing that, and he wants to expand that service further. And the head and deputy head of pharmacy was saying, what's great is it means pharmacists then can be freed up to do the things that only they can do. And she was saying, this is really where we've got to go in our future workforce model. So not only was it a great individual story about his success, but also shows what great things are happening in different departments. So I've got a bit of thought, maybe we might at some point in the future bring some of those award winners to something with boards, so you can all have the opportunity to meet them, because I think there's also something about recognising those individual members in our organisation. So really, really positive. And my final point was just to say a big thank you also, because again, this is something that's, you know, a big piece of work that's happened in the organisation we haven't heard much about recently, but every patient who died during COVID through nosocomial transmission has been, their cases have been reviewed by a nosocomial team within the health board, and relatives have been informed of the outcomes of those individual cases. That's been a hugely challenging bit of work, not just in terms of the number of numbers that we've gone through. So we've been through 3,233 cases here at CTM with that dedicated team, but you can imagine also the emotive nature of dealing with the families who lost loved ones through the COVID pandemic in our facilities has been really challenging as well. And I have to say, my measure of it is I've only had about 1 or 2 queries from families about the process. Everybody else has been very, very satisfied with the outcome of that process. So I think we have to say a massive thank you to Debbie and Alison, who led that process in Greg's team, really sensitively with a really difficult subject matter to deal with. And I think, you know, it's now been closed down as a programme of work because we've done all of those cases. But just to say a big thank you on record to those individuals for that really important piece of work that was obviously really significant for those families involved. But that's everything from me.
Thank you, Paul. Lisa, and then Nicola. Thank you.
2 things from the report. Can I just say well done and congratulations to the comms around the maternity services, because the pictures of the new babies on the Twitter and things like that, really positive, and I think that's having a huge impact in the public about seeing positive news stories. I think that's probably more powerful than just saying we've de-escalated. So it is lovely to see all the new babies. And just a query from me around the delays around the discharges. The task group really positive, but do you need a social worker on that group? Because obviously that would impact, because the narrative is around what we do together. So rather than it just be health led.
I think that would be useful, Lisa. I mean, I think what we wanted to do was make sure we got our own house in order first. But I think you're absolutely right. There is a need for us to think about how we do that in conjunction with that. Something I would think threats without outside.
Yeah, thanks. Nicola and then Rachel. Yeah.
Okay, thank you. Picking up on the Seven Awards, you are right, Paul, it's great because not only are we celebrating individuals, but I think we are getting out there how diverse we are as a health board. You know, it's not just about nurses, it's not just about doctors. We have a whole range of different professions you can go into. My only one thing, and I have raised it with Simon, is it's dropped off our Facebook page. So you have to go on to SharePoint, and we all know a lot of our staff don't access SharePoint. So it's a limited amount of staff that we are sharing this information with. So can we please get it back onto our Facebook page?
Yeah, so we've done that. So thanks for your heads up last week. The team have worked on a little collage, which is going to go out this week as well. But just to say, it goes onto SharePoint, but it also goes onto our staff update newsletter, which goes out to all 13,000 staff every couple of weeks as well.
Staff don't read that.
No.
There was Facebook, a lot of people will pick up on that.
Yes, it's a number of things. Yeah, thanks.
Thanks. Rachel.
Just to follow on from Lisa's point about including a social worker in that group, then also the third sector.
Yes.
To make sure that we close the loop there and it is a whole system.
So definitely.
Thanks. Good idea. Thanks. Okay. Any other questions to Paul? Yeah.
Just to say, from the nosocomial programme perspective, that's something that's been raised as concerns all across Wales, similar to the update I gave on email. In contact Morgana, that's not something that's been picked up for us. Hence, we haven't had many discussions. That's a really positive thing here. And secondly, just because it's public concern and shared by my colleagues as well, all health boards were asked to submit revised plans for the year due to the cost pressures, the additional savings that are requested to be made. So what we've got today is Contact Morgana's IMTP is fully balanced with all the savings that were expected as well.
Yeah, so we weren't asked to resubmit a plan because our financial plan for this year was a balanced financial plan. All what we've had is sort of a narrative commentary back from Welsh Government about a few of the sort of priorities that we've chosen to make or not make within our plan. But on the financial side, no requirement to resubmit. But you're absolutely right, Daniel. There are other health boards have been asked to resubmit their plans to improve the financial positions of their plans.
And just say that that's the priority that's been picked up by other colleagues, but not something of concern in our region.
Okay, thanks, Daniel. Cheers. Okay. Okay, we're happy to note the Chief Executive report. Thank you very much. Item 5, moving on to the Board Committee and Advisory Group highlight report. So I can just go to the Charitable Funds Committee highlight report first. There's a report in front of you, Sally. An update. Are you?
So the charitable funds. Sorry, I'm expecting the.
Oh, sorry, apologies. But we've got an update report. Just wondering if there's anything that
Nothing specific.
Nothing specific.
The report, no, with the meetings.
Well, the only possible I would mention to that is we have our new head of charity. We had a really good recruitment process a month or so ago, which Linda was involved in, and our new head of charity income generation will start with us on the 12th of June.
Terrific.
So that's going to be a really important role.
Absolutely great step forward. Thank you, and thanks for updating the board. Any questions on the update report? No, colleagues happy to note. Thank you very much. Stakeholder reference group highlight report, the 11th of April this year. Anne, anything to update colleagues on?
Only in the alert section, the minister's approval has come through now.
Okay, great. Terrific. Good to hear. Thank you very much. Any questions to Anne on the update report? No, just note the update. Thank you very much. Item 5.1.3, the Quality and Safety Committee highlight report. Carolyn, I'll come to you for this one. Thank you very much.
Yeah, just to highlight under the alert escalate, we had a significant discussion about the issue of boarding patients. This is of huge concern, I know, to everybody, but specifically to our committee. We had a lengthy discussion on that and some requirements of reporting back to that board, but we really wanted it to be highlighted here. We understand we were given some assurance about individual risk assessments that are happening around this, but generally huge concern that this is not something we want to be doing, the impact on patients and staff. And I think it refers to your earlier point about this whole system issue. But the worry, I think, of the committee is it's almost become normal practice that as part of this crisis in the system, this is what we're doing, and it allows other people to not necessarily make decisions they might have to. So I know everybody's aware of that, but I did want to highlight it here and say that is going to continue to be a significant focus for the Quality Patient Safety Group.
And we shouldn't be normalising behaviours just because it's just the way it's happening. Like if people are being delayed in hospital needing to leave, or whether it's those people being ordered, yeah, absolutely right to flag it up.
Yeah, just on that point, we had the first joint commissioning committee a couple of weeks ago, which obviously now incorporates the previous East ambulance commissioning. And there was a big debate about this whole pathway and the impact that obviously, and interestingly, just as a bit of insight for colleagues, you'll know that Cardiff have made some big progress around their ambulance handover times. But interestingly, they've not seen a reduction in their red response time in Cardiff. So Suzanne is rightly raising the question, even when we're making changes in the hospital side, we're not seeing the ambulance service response through, because often the narrative is we have to put people onto wards to board, so frees up beds in ED so we can offload the ambulances, which then enables the ambulance to get back in the community. So one of the things I think we need to watch is not just the metrics around the boarding, it's what's happening through the whole pathway. And one of the conversations we were having at the JCC was how do we also get better at commissioning from the ambulance perspective to make sure that actually we're not conveying people to hospital in the first place who shouldn't be coming in. And I think we are still seeing, certainly in our patch, quite high rates of conveyance to hospital of patients that could be dealt with in a different setting. And that in turn, Caroline, is part of the impact that we then see of boarding patients who don't need to be there. So I guess it's absolutely right that we focus on that end point from our side of what we could do to mitigate this. But also we've got to look at the whole system flow, because that's ultimately what's resulting in these sort of blockages and then ending up with people being in the wrong place.
Thanks, Caroline. Any questions to Caroline on the highlight report? No? Okay, we'll note the report. Thank you very much. The hosted bodies Audit and Risk Committee highlight report from the 18th of April. Patsy, thank you.
Yeah, just a comment on the Escalate section. We held the hosted body just before it became the JCC. The interim Chief Commissioner, Abby Harris, gave a very thorough update to the committee that was very helpful. And just to say, there was a different feel about it. It felt more collaborative. It felt how it should really feel going forward. And then one final point is to say the legacy documents are all on the consent agenda for next month's Audit and Risk Committee.
Thank you, Patsy. That's really good to hear. Any questions to Patsy or any comments?
Yeah, I mean, just to reinforce what Patsy just said, I have to say the JCC that we had this month felt a very different type of meeting. And also we've got a chief execs and JCC development session next Tuesday in the afternoon with the IMs and the execs from the JCC to talk about that sort of how we work together moving forward to make sure that it's done as a joint effort, which I think is a really positive development.
Okay, thank you. Okay, item 5.2, the escalation status update. Paul has covered this in his report, so I don't think there's anything else to add to this. Item 5.3, the board assurance framework. I'll hand it to Gareth. Thank you, Gareth.
Yeah, thanks, Chair. Thanks, John. This is the regular report we obviously bring to each board meeting. As you all know, the board assurance framework is very much a live document that is continually updated throughout the year, and my thanks to everyone involved in updating those risks which underpin this document. Just draw the board's attention really to section 3. We talk around significant updates during the period since we last met, and the significant amount of work has gone on in terms of reviewing strategic risk 3 around workforce, including an update in the way that risk is described. And then you remember at the last board meeting we closed off our previous financial risk due to the fact obviously we're in a balanced financial position. But just to highlight the fact that a new risk, strategic risk 10, has now been created around failure to plan and manage revenue resources within the revenue resource limit. And then things in development, things in train at the moment, development of a new risk around capital and estates, and obviously ongoing work as well around reviewing our risks around leadership and culture, which I know has been undertaken by Howell and the people team as well. So we'll say this remains very much a live document, and increasingly will be a really important tool as we move towards a new way that we support the board going forward. The details against the updates of the risk are in Appendix 1 in red text as usual. So at that point, I am back over to the chair and any questions board members may have.
Thank you, Gareth. Okay, any questions to Gareth? Patsy and then Kath and then Rachel. Thank you, Patsy.
Just one on risk number 1, and it's been rated as 4x4 for a long time, and I understand that, and I read the detail and understand the detail. But is the likelihood really for, because we've heard about staffing shortages in endoscopy, we know the ED waits are very long, I don't know if that's space or staff, we know the ophthalmology, trauma and orthopedics, we know all these waiting times, we know we're still in a sort of enhanced monitoring for waiting lists. Are we really at 4, or is the likelihood of not having sufficient staff in hand and emergency care a 5? Because is it happening?
It's a really good point, Patsy, and actually one of the conversations we've been having is trying to make this a subsectioning this risk, because I think we know our plan for planned care, we probably are in a better position, and our position on emergency care remains exceptionally challenged. Equally, this risk doesn't allow us to identify where we've potentially got capacity. We've board level assurances required around some of our other services. And so what we're working through at the moment, so hopefully in a couple of iterations, we'll have set out strategic risk 1 to subdivide it from planned care, emergency care, and some of our other services, so that we've got that level of sensitivity, because at the moment it is all just one score, and I don't think we're therefore being able to hone in on the specific assurances required for those specific areas.
Kath and then Rachel. Thank you.
Yeah, thank you. Yeah, I mean, I welcome the work being done around the new risk around capital on the estates, because, you know, as you go aroand and you see the services, you can see that there's really massive challenges around our capital budgets and our estates as well. I think I'm glad that that's been looked at. A question around leadership and management. I know, you know, the care groups are still relatively new, so I'm just wondering whether we could have a bit of an update on the sort of bedding in of the care groups and sort of where we've got to. And then the final point was really, I suppose, should we have a risk of failure to move services into the community and sort of primary care and try and keep people out of secondary care? So it's a very general sort of comment, perhaps not to be answered now, but it's that risk of us not moving out of secondary care into primary care and that care closer to home. Thank you.
Rachel?
Yeah, just on page 14, a question around the shared listening and learning forum, which is being paused at the moment to look at merging with us. I was just curious when they'll be reinstated. When is the kind of the review of all of those groups being concluded? I would be concerned if it went on and on and on as these things can.
Yeah, okay. Right. Okay, thanks. We'll take that back in. Great.
Yeah, thanks, Rachel, for the question. So we paused it essentially because of phase 2 of the OCP. We're relaunching so we do 2 face-to-face learning events across the patch. We're relaunching it on the 22nd of June, I think. And then subsequently then every quarter we'll go back to a Teams event, but twice a year a face-to-face event.
Oh, great. So
it's happening.
I've got just a brief question. That's all.
Sure. Yeah.
And they are just for my knowledge and understanding more than anything. On page 19, improving flow and efficiencies and productivity. There's an appointment to be made there, I can see, and I just asked when is that going to happen. Let me just have a look at the. Sorry, I'm going to post. I'll just take up the roles. Oh yes, recruited and appointed to Porcel, or Porcel has not yet commenced. But it's imminent, is it? It's the sorry, I can't see. Doesn't matter. I'll check with Greg another time. It's okay.
Okay, thanks.
Lovely, thank you.
Can I come back to Gethin on the earlier question?
Yeah, on the cable.
Yes.
Yeah, by all means. We completed phase 2, and we appointed to all posts within phase 2. There are 1 or 2 external appointees who will be starting over the course of the next month. But just in terms of the recruitment, about a third of the appointments made through phase 2 were internal candidates within existing roles. A third were internal promotion, and a third were external appointments. So we've got a really nice mix of teams. The new director managers, clinical directors, and heads of nursing are all settling in really well, and progressing into their services. We had a care group launch event, which was really well attended event a couple of weeks ago, where Paul opened it. We went through sort of the priorities, had a really positive day. That's going to be a 6 monthly event with the care groups, and that will allow us to help develop and support. But I think it's it's taken 2 years to get there, but actually what we've now got is a really strong leadership team at the care group level, and I think we've got really strong leadership teams now at a directorate level. In addition to that, we've also made 2 clinical appointments to the site medical leads. So we've appointed Dr. Chris Goodwin as the site medical lead for Princess of Wales, Dr. Rob Martin as the site clinical lead for the Royal Glamorgan. We're still going through recruitment process for Prince Charles, but a really positive, again, strengthening the triumvirate who lead our 3 acute sites, to strengthen that. So it's positive progression on the phase 2. We're just now doing the final bit, which is the lower bands, but that will be done at a group level, not as a whole organisation level.
That's Kevin.
Yeah, just going to mention about leadership development.
Yes,
so
thank you.
yeah, so that I think that's all been really positive, and it's been a really positive experience in terms of the process we use. So we were able to gather quite a bit of data on all of our talent internally, but also who we've brought in. And as part of that process, we redesigned our 2 flagship leadership programs, one of which will be specifically delivered for care group leadership teams, and then the other will be delivered then for directorate leadership teams then essentially, and that's got quite a bit of diagnostic upfront work, bit of psychometric 360, and also general diagnostic. We'll take them through the programme, and the first cohort will be the care group leadership teams, starting I think fairly soon in the next month or so. And then obviously we will take that through the organisation and train as many as we possibly can through the leadership programme. So really optimistic about that, and we've had really positive feedback from the care groups in terms of the investment that's going into them, and also on the process we use for the recruitment process as well. So obviously we'll continue to feedback on how that's going.
Linda.
Can I just comment on your suggestion about a risk about shifting services into the community? I would like to go and have a think about that, Kath, because it's possibly more in my mind in the realm of a failure to deliver on our strategic goals, which includes that. And that's
fine. It was posed as a thought question rather than on the leadership question. Thank you very much. It's really useful because when I go out and meet with staff, some of the staff are saying they need a chance for the care groups to bed in, and it's probably staff who are on the lower grades as opposed to the senior management as well, who are sort of commenting on that as well. So I'm really glad that we're going to do leadership throughout the organisation and give everyone a chance, because everyone's play a sort of leadership role, can't they?
And I should mention, that's a really good point. Actually, we've also redesigned our kind of entry into leadership aspiring leaders program to make that a bit more practical, actually. So some of the things that we struggle with from a practical perspective, as well as some of the more developmental leadership elements. So I think everybody now has an entry route into a potential program right to the highest level. So I think that's really positive for us.
Thank you.
Okay, thank you all very much. Colleagues have been asked to approve the board assurance framework. Are colleagues happy to do so? Thank you very much. Moving on to item 5.4, the annual review of board effectiveness self-assessment. As colleagues will be aware, this is a substantial piece of work that health boards are required to do on an annual basis. I'm delighted to present the report, which is before the board for approval this morning. This is a very detailed piece of work that's been undertaken by Callie and the team. So there's an introductory report, and there are some accompanying documents as well, which set out the background and context, but also the depth of the work that's been undertaken to look at a variety of factors which help us to understand how effective we are as a board. And this has also included, of course, consultation with all board colleagues. I think many of whom have responded to the survey that was sent out by the team. And as a consequence of that, it provides us with our own self-assessment as to where we believe we are at. And if you were to look, for example, at page 10 of the introductory report, where we've considered a range of issues that are set out earlier in the report, the board was asked to consider the level of maturity for us as an organisation, and the largest number of responses that came back from colleagues demonstrated that our maturity rating would be set at level 4, taking into account all of the factors that are set out in the report. I think that is a very healthy place for an organisation to be at. I think if colleagues come back and said, we believe that we are definitely at level 5, I'd be saying, well, there's always work to do. There's always work to do. I think there's always a level of caution to put in. I think it's good to recognise the enormity of the progress and the sustained improvement that we've seen. But likewise, there's always that feeling that there's always more to do in improving how we as a board operate, how we discharge our functions, how we are organised, how we are resourced and supported. So, yeah, but likewise, if they'd come back and said level 1, I'd be absolutely terrified as to why colleagues thought that was the case. But so I think it's a really healthy process, a solid self-assessment. I'm really grateful to the team for the work that they've done. Any questions on the report or the accompanying documents? Any questions about the process or the output? Paul?
Just one quick comment from me, I guess, is it came through from the comments around board development being welcomed, and that sort of why, not just topic-based board development, but how we together as a board work. And I guess that's what we need to think about, Chair, and with Gareth is, and how do we start to get that process in train now for the next 12 months, given that our board sessions are always quite packed and our development time is already quite occupied, so we need to factor in perhaps some time to think about how we plan that in now for the next 12 months.
No, I think that's a really good idea. And from my perspective as chair, what I've been very keen to ensure is that our board development sessions are there to support board members to understand further about key areas of our business that we are seeking to develop, to change, particularly where those items will then come to a formal board meeting, perhaps for a discussion and a decision. So there needs to be a relationship between that which is discussed in board development session and that which comes to board. The one has to support the formal discussion and decisions that we take place in these public board meetings. So, and I know it's a good opportunity to flag other things up, to talk about, for example, a range of subjects, but I think just trying to make sure we focus our efforts in those board development sessions in supporting colleagues' understanding, developing discussions and thoughts about the sorts of things that will end up here in formal board meeting, I think is really sensible. And bear in mind, we've done a lot in the last 12 months here. We as an organisation, we've gone through a review as part of that broader board effectiveness review, looking particularly at our committee structure. So, yeah, and I think we're the only health board in Wales to have done that and to have been quite thoughtful, quite radical, I suppose, in terms of what we have decided. So, yeah, but it's about making sure and continuously reflect on all of this. And I've said before that in terms of the decisions we took on our board committee structure, we'll see how all these things work, and we will make changes, where we need to make changes. So I think that's also quite a healthy thing to do. Patsy, on this?
Yeah, just on the level 4, it's a pity there isn't a scale within that. We are further along than we have been in the past, and the straightforward answer is it's a 4, and you know, whether it's the beginning or the end of the 4, that's where we are. And just to be really pedantic, because I don't know where this presentation is being seen, but on the slideshow at the end of the attachments on page 2 of it, talks about how IM's been involved at a strategic level. Absolutely. Responsibility for operational decisions sits below the board. I think really the operational decisions sit with the executive, don't they? It's the implementation that is below. So I don't know where that's being used, but if it's used, I think that just needs.
Yeah, okay, we'll make sure that changes. Linda?
Well, it's funny, I was just wondering whether to pick up on that chart with all of the ticks in the 4 except 1, and just not to brush over that, and perhaps I've obviously not just know who that is, but maybe that there is a chance just to find out why that person feels like that and what might, you know, make a difference there, because that'd be good learning.
Yes, absolutely.
But that person would need to identify. They might not want to. So.
If that individual wanted to email me privately, that's fine. Perhaps we can pick up on those on any particular concerns that can be addressed. Kath?
Yeah, no, I just want to say I thought it was a very open process, and I think I just want to say massive thank you to Gareth and Callie and the team. It's a very, very small, lean team for the size of the organisation that the team was supporting, and I think it's been an excellent piece of work, and just want to endorse what you're saying, to thank the team really around all the work that's been done on this.
Thanks, Kath. Okay, unless there are any other questions on the process and the report, the recommendation is that the board approve the annual review of the board effectiveness self-assessment, and that we agree that our maturity level is identified at level 4. The assessment will be reported in the accountability report, and just to say, as set out in part 3 of the opening document, in concluding this process and in demonstrating continued self-reflection, as well as an appetite for continuous improvement, as I've set out, board members were asked to identify areas of activity or improvement. That's captured on page 11 onwards. So, you know, the approach now will be for our governance team to reflect on that, to think about how we address those issues, you know, over the course of the next 12 months. But this is a very healthy process, and I'm really pleased with the outcome. Are colleagues happy to approve the board review? Well, thank you very much indeed. We are very slightly over, but I'm conscious that Dale has joined us for the next item, which is the item 5.5, which is our working and partnerships report, but it's specifically around the development of our Maesteg Community Hospital site. Dale, as I said earlier in our introduction, is our Assistant Director of Transformation, and we've got a presentation, so I think we'll deal with this item first, and we'll have a break afterwards. But I'm really keen for colleagues to have the opportunity to hear the presentation update from Linda and Dale, and to discuss where we've got to with this incredibly exciting programme of work that Dale is leading in Maesteg. So am I coming to you first, Dale, or straight to Dale? Dale, straight to you.
Straight to me.
Right, Dale, good to see you. Over to you.
Good morning, everyone. Rather than focusing on the slide, if we click on, and then we'll come through with any questions at any point, just shout them out as we go. But I guess,
Say next slide, please.
I was going to say, yeah,
Downing Street fashion.
Last time I did, click on, there we go. If you can skip on to the next slide then as well, thank you. So as many of you know, Maesteg Community Hospital has a very long and locally treasured history, built in the 1910s for and funded by local miners. In fact, so the first patients back were soldiers back on the front of the First World War. There is a strong community attachment to the hospital. In fact, many of the residents, the older residents, were born there, so there's a direct attachment to that site. But there has been a steady degradation of services on that site over decades. And I'll be frank, there's been community expectation of closure until Paul stood up at the first community sessions we had in January last year. And the tension.
I didn't decide to say it on my own back.
Until, yeah, the tension very quickly went from the room, shall we say, the minute we said it wasn't closing. And through those sessions through the first 6 months of last year, there were 7 very public engagement sessions, including open to the public, as well as identifying those sector and community groups. And there's a huge range of feedback around identifying, one, the health services that people were accessing and what they felt they needed, as well as understanding more the drivers of health inequalities locally as well. I won't go into detail there, it's just to say as we go through those issues and items that have been identified in the community are reflected in the things that are now under active consideration as part of the development. So if we can move to the next slide there. So this captures essentially the range of health services, care services, well-being services, as well as the national and CTM policies that are actively being considered at this point in time. As I say, the opportunity for funding comes from the Integration and Rebalancing Care Fund. There is a finite capital amount of money available with that as well. So that is being considered along with this range of services that we are doing, plus extensive ongoing engagement with the community within CTM and our partners externally, including people such as Slice through the programme board and others. So if I just quickly, over the next couple of slides, just give you a quick sense of the health services that are being considered, and they reflect what we heard very much internally as well as through those community engagements. So we have bronchial gland surgery on site at the moment. They will very much be retained, and there is the opportunity there on that site for primary care expansion, again meeting the needs that we are seeing locally. Items such as the urgent treatment or urgent care centre, again on the day illnesses, the potential for a minor injury and illness type of facility. Again, there is already on site an X-ray machine, which is having additional investment to be brought up to more modern standards. So that piece of kit is old at the moment, but that's an opportunity with the Welsh Government there. There's the opportunity for increased range of outpatient services and minor procedure treatment rooms for across a wide range of clinical specialties, particularly women's and children's, help as well linked to that. One of the stats that scared me in my early days here was a third of children and young people from the north of Bridgend, particularly from my state, aren't attending appointments at Princess of Wales due to access and travel costs, etc. So the impact through life of that is quite significant. But again, many of those services do not require specialist rooms, specialist areas of treatment. It is about timetabling and considering a different way of working to allow obviously working for Princess of Wales and then up in the spoke then. Princess of Wales is the head of the spoke at my stake. Again, working closely with the therapies team to understand the offers there, as well as obviously we have a very strong community mental health team already in my stake. They would very much be retained, but actually there's a wider local primary care provision around mental health as well that is distributed right across the community. How best could they utilise some of the services and partnerships that we have there as well? And then again, community dental services, sexual health clinics, again, are actively being considered as part of this. But I would say at this point, we understand the need that it needs to be revenue neutral, needs to be different ways of working within the existing costs and funding envelopes that we have. There's a lot of work ongoing through workshops at the moment to understand how that could be done. But again, the last point on there, obviously the opportunity to increase utilisation of digital services and what does that offer, particularly in relatively remote communities such as the Flinley Valley. In terms of care services, you all know there was a ward, the Flinley ward at my stake up until through COVID. Again, no decisions have been taken, but there is ongoing work with the team to identify how and what intermediate care services or ward unit could be at my stake. The direction of travel at the moment is around pathway 1, pathway 2, D2RA beds, so rehab and reablement, getting people out of the POW and home as quickly as possible. From a wellbeing perspective, we're doing a huge amount of work with the local authority. They've been very forward-leaning, strong engagement there. Bridgend Integrated Network Team North, for example, social services as well as CTM, UHB teams currently based in Glanreed, but working in the north. The aim there to move them into the patch where they operate in. Children's services at BCBC are really active and keen to utilise a redeveloped site for more activity in the north, which is great. As well as ongoing conversations around the front of house activities that the local authority deliver, so benefits, community housing, all those services which currently you access predominantly online, but there are in-person activities, but that is limited in the community. So again, how can we link in with those there? the opportunity for a community cafe. But the key thing for me here is how we integrate all those other third sector wider organisations to broaden and increase the access to those. They're extremely important provision that is delivered outside of health, but has a fundamental impact on health and well-being. And we focus on calling them my key anchor partners, predominantly as they represent a wide selection of services and charities in the area. So Bridgend College, Barvo, obviously mentioned the local authority, they are interested in citizen advice and mental health matters. So they help us co-create a vision for what those well-being aspects and well-being hub could look like. And we'll just skip quite quickly, but obviously we are cognizant not only of capital, not only of revenue, but also we make sure we commit not just CTM 30 and internal policies, but broader national policies as well. Thank you. Thank you. Great, I won't take too much time here, but ultimately we know in the north of Bridgend, Cairo in particular of my stake, there's a huge number of health inequalities, trouble accessing services. So we really are trying to address those broader issues that impact on people accessing health and well-being. I mentioned the number of did not attend appointments, and many could not attend simply for travel reasons and costs, etc. The opportunity to reduce the number of late presentations for a range of health issues, and that's in particular for women who are presenting late with a number of health issues, again for the similar reasons to children and young people aren't attending. Again, we know Findlay Valley residents do attend PW in their strong numbers and access an A&E, particularly for urgent primary care and urgent illness on the day, which is what's driving the consideration of our urgent care centre to reduce the pressure we see coming through the door in Bridgend. We've mentioned opportunity for intermediate care, but again, also improving awareness, access and utilisation of those third-party services, which can make quite a big difference to people's lives. Next slide, thank you. And just to say, I won't focus too much, but in terms of how we look at the design principles underpinning the development, the key is that clinical spaces will be flexible and multi-use. Wherever we can, they won't be dedicated to a single service with a locked door that's utilised 1 or 2 days a week. The aim is that they will be accessible by all services at any time that they are needed, and again on a very much timetable bookable service. To avoid some of the challenges that present of locked doors. In terms of non-clinical spaces, around no individualised desks, smaller desks to maximise the space available, no single occupancy offices, for example, and then meeting rooms will be shared by all departments, they will be bookable, and those shared common spaces that come with that as well. And I'll also say the most important thing for the community here in terms of building features that must be retained. If nothing else, and from my stake, and the last thing, I won't be able to access the valley beyond the life of this project. So in terms of coming out of those extensive community engagements that we had, there were 3 key things that are identified by the community for retention. The external facade, so the traditional Edwardian look of the building from the outside, must be retained. The outpatient reception tile, which are back to its history as a maternity ward, staff in particular, as well as the community, are really key that they will be retained. How we do that, I will allow others smarter than me to figure that out, but that's when. And then, as many of you will know, my stake has far too many entrances with opportunity for people to access the site in different ways. So again, what could that single entrance look like with a large reception with large common space areas as well to manage patient flow? So yeah, we get into the crux of it now, which is quite interesting. So my stake is currently 3,100 square meters. As we've done, looking at what the community has said they would like, looking at the services we can potentially deliver at the moment, including modern healthcare standards, for example, which does increase the size and space that we do need to have. It's currently showing and suggesting anywhere need between 4,200 at the lower end. And if we were to do maximum, absolute maximum, everything in there, it would drive it to 7,500 square meters. But again, the likelihood there is that to be on a much lower end of it. But as part of the development of a joint SOC OBC, we do have to demonstrate that we considered options ranging all the way from do nothing, all the way through to absolutely do maximum. With then the decision around the preference and the drivers around that. So we are in the middle of extensive workshops with internal teams and external teams to understand and define the exact need and the requirements. But ultimately, the numbers are such at the moment that benchmarking with our cost advisors and supply chain partners, based on the very latest estimates of ongoing schemes, says capital costs of roughly £10 million per every 1,000 square metres. So there's been a significant increase in those costs, as you would imagine, through COVID. They are having an impact. So again, on that 4,200 figure, it would come in around the 42 million at the moment, all in, albeit we are having ongoing engagements with Welsh Government to understand IRCF capital and availability of funding, including when, as well as their appetite around the size of schemes. There's lots of ongoing engagement to make sure we hit the mark in terms of this scheme. And just for awareness there, so we do have current funding of 476k to undertake a joint SOC OBC. The majority of that funding covers the cost of external partners, so MESA project managers, leads and cost advisors, and Kia Construction, who would be interested in, have done a lot of health and wellbeing hubs very recently, which is why we're quite confident in the numbers in terms of costs at the moment. They bring along the architects and others, but it covers their costs. So we do have an additional request in the Welsh Government, which they are expecting and we're expecting, to help us cover the cost of additional surveys and everything else that we need. Again, it's an old building, there'll be a number of gremlins that exist within there, as well as all the local issues that we have. So the aim there is that will allow us to minimise risk and obviously reduce the costs we can see moving forward to avoid any unnecessary missed costs that we need to do there. Okay. And that's just to say examples of what the space could look like at the moment. Again, we have to exist within the existing boundaries of the site. There would be no opportunity, for example, to expand it. This site self-contained, and we do then have a challenge of the car park, which many of you know is owned in trust by the Duke Estate and held in trust there by the local authority. But we are having extensive negotiations and discussions now with the local authority around the future of that car park and how we can make best use of that site. As we understand at the moment, the trust line says that it should be held in trust on the behalf and good of the community. What that means is an interesting debate. A multi-million pound investment in the health and well-being of the community for another 110 years. Enabled by that car park, which we know we need to do, would seem like a justifiable reason of use of that site. Let's stick to the next slide there. So in terms of risks, obviously, key risks that we go through, again, ability to deliver the planned healthcare services that we want on a revenue neutral basis, so working differently but within the same cost envelope. Availability of capital funding to cover the envisaged scheme, again trying to mitigate those risks by continuous dialogue and conversation with the Welsh Government and the IRCF team. And obviously I mentioned parking there being a risk. We know with increased activity at the site there will be increased parking and car park requirements, as well as then obviously there are challenges around the lack of public transport, and we are going to need an active travel plan. But again, strong relationship with the local authority, so we are trying to mitigate those as early as we can. I say just in terms of timeline, so in green there we are in the midst of a service requirements workshop at the moment. They continue through June. As we get into the summer, that will allow then our architects to take what will be a full schedule of accommodation developed. And they can take that into a design then over the summer. With that does come initial costings as well as a design. So you get the square meterage final outcome plus the costings. So that allows us then as a line in the sand for discussion with Welsh Government to make sure before we proceed beyond that in terms of developing the design and requirements, that we're on firm footing with Welsh Government. That will continue in terms of engagement with planning and highways, the writing of the documents, etc., through the remainder of the year. And then through January and March next year, those documents will then go through the relevant oversight committees, including board, before plan submission in March next year. Welsh Government then have 3 months to approve, come back with comments, such that by the middle of next year we should be into developing the final business case approval, with submission certainly no later than the middle of 2026. Some of these timetables will be determined by Welsh Government upon receipt and approval of SOC OBC. But all being well, the aim would certainly be to start redevelopment, whatever that looks like in whatever form, sometime in 2026. In terms of the build after that, that will be determined based on the size of the schemes, but certainly around 2 years development. So as part of that, we will also need to consider obviously the decant of services that are currently there. So that's very much part of the sort of OBC development. And essentially that's the last slide. So for today, it's just obviously the board's previously endorsed the development of business case to move forward. So it is to note where we are and all the items that are under active consideration at the moment to make sure we meet all the requirements set out by board and community as well. Thank you.
Dale, thank you very much. And having visited the site, and seeing the scale of the ambition, I think it is really encouraging that we are looking at what is a significant, it's not insignificant, strategic project to meet the needs of communities who are really quite disconnected in other parts of our region. And there are a whole range of communities throughout the whole of CTM, and the Vice Chair and I were visiting Caira yesterday, and you get to see at first hand the real challenge people have of accessing services, a variety of services, not just health services, but other services as well. And I've got fellow health board chairs whose health boards cover significant rural communities, and whenever they talk about those areas, they talk about access, about the difficulties of rurality. We've got very similar principles and challenges here. We're not rural, although a good chunk of the region does look rural from certain angles, but we've got significant population areas that have the same level of challenge when it comes to accessing services. And for me, when I look at this, look at this plan, look at what is being taken forward, accepting that we have to make the case to Welsh Government to support those business cases to ensure the resources are there. When you look at the data and look at those people who are not accessing services, look at potential for us meeting the needs of those whose current needs are being unmet, I could see this being a very busy site in terms of what it seeks to provide and what people have the option to access. So I'm going to start first, then Paul.
And obviously, this is quite an exciting scheme.
Yeah.
But one of the things we need to do is make sure that it meets the requirements for the ICRF, the IRCF actually. Certain initials go around in circles in this, which is about focused amongst other things on developing health and care centres across Wales, and the aim was for around 50. The original allocations was something in the region of 50 million year one, 60 million year two, 70 million in this year, and then we are yet to find what it's going to be in future years, but we are expecting it to continue, obviously, as we're all in the process of developing business cases. But that gives you a sense of the sort of available funding for a number of schemes. I think we originally estimated this one at about 15.5 million a year ago. The feedback from the capital review meeting on Friday was very much about we need to be careful that we don't go beyond what is affordable within this scheme, or it would fall into all Wales capital. So I think we are going to have to make sure we have sort of an iterative process to make sure that we can still hit that scheme requirement.
Thanks, sorry. Paul.
What I was going to sort of following on from Sally's point, I almost think that's got to be our expectation, and we work back, and we almost got to work back from that. I mean, I think it's great what we're doing on this project. It's a really good example of thinking about the inequalities that we know exist in our communities and thinking about how we then respond to those. I'll caveat that with saying, I also know these things. When you get a group of people in the room and say, what would you all like? Suddenly, before you know, we've got everything and anything under the sun in one building, and hence why the costs then start to escalate. So I think there's something about here, how we, go through that collection of all the ideas, and then we have to sort of hone it down and say, okay, so, and then, it's great, Dale, that you're talking about things like multi-purpose space. So it's not, my link to that, I guess, my question was, we've got a lot of external partners in the room in these conversations about opportunities for working with them. But we're running this through a health service traditional process, which with it comes, as you've just articulated, a cost per square metre of like a clinic-based facility. Well, a lot of these people, if they were building it down in my state town centre, wouldn't be worrying about any of those. So I guess my question is, is there a possibility in this to sort of segment the sort of site into areas where they're perhaps less liable to some of the NHS sort of health regulations around space and cost? Yeah, the building standards, and maybe an element of the space is a community type of approach, which is actually subject to a different type. Because I just worry we're in danger of escalating the cost by nature of all these things coming under the site, which is the right thing to do because it's a great facility and opportunity. But I just it's just getting perhaps a bit of advice about how we might be able to sort of make sure that the health regulations applies to stuff that is very clearly health, but that we don't end up over professionalising stuff that doesn't need to be that costly. And I don't know, it might just be worth a conversation with the people we've got working with us now who perhaps worked on other similar.
Here, we're a main supply chain partner. They've worked extensively with the team Arcadis with their architects.
Yeah.
They've got 3 current centres, one in an Island Bevan Health Centre for Tredegar's open with these similar spaces.
Yeah.
Newport, Ringlands, again, very similar health challenges to what we're facing in Ringlands. They had to work in a very similar scheme there. So all their best practice, all their knowledge, including some of how we do it effectively, they are bringing with them.
Linda and then Ian.
Well, I was just going to say that the first doubling of the cost from the 15 is literally the doubling of construction costs in that time, because that 15 was based on the Derry Stamps developments. We didn't have anything else at that point in time. We didn't have any external people to tell us what, so it was literally, so it was always undercooked. And I guess your point about the size of the national pot is a constraint. We've got no choice. We can only work within whatever constraints they apply. But the fact that they are spending that amount of money in Newport, in Tredegar, in other places now, there's no reason to underbid, is it, for something as important as my stag? But clearly we're expecting to, come up against the kind of what's available.
I will say we're a pathfinder at the moment. So while ICF has funded other activities such as this, we're the first to go through a joint SOC OBC approach, which is 2 of the 3 business cases you'd usually do separate. We're now combining. We are the first to go through that process. So it is an iterative process for us internally, how we manage that development through those joint business cases. But it's also a bit of a lesson finder for Welsh Government at the moment in terms of how that looks and develops as well. Because traditionally, we would have had many of these costings worked up in a more detailed nature at SOC. Before we went then to OBC, but obviously as we've had to do it combined, some of these are coming out through the wash as we go through the joint process. So we standardify these costs very early in the process as opposed to having gone through it in a very sequential basis, SOC, OBC to FBC.
Yeah, I mean, hopefully the NS for my stay is now in the cabinet. So that gives us an opportunity to do some political, and Dale's got a good relationship, I think, with her. I mean, I think that's the other thing we've got to say is that Dale's work behind the scenes on this is really important, because this is a really important project, as you say, Dale, not just for us, the health, but for the community in my stag. And I think, given the importance strategically of that site, but also given its strategic location for us in that valley, and what was really stark when we did those engagement events was the feedback from the residents, just how difficult it is to get down to POW for simple stuff. There's no point booking an appointment at 9 o'clock in the morning because you can't get there on the bus by 9 o'clock in the morning. So transport is a really key player in this conversation.
So Ian and then Gethin.
Yeah, as I mentioned before, I'm a resident of my stag, and actually my childhood was spent in Caira, so in the most deprived area. So I understand a lot of these issues. And this will go down really well in the community, and I think it is going down well in the community. From that first meeting where you stood up, Paul, and diffused the meeting, which we mentioned earlier on. But yeah, it's having great feedback, I think, in terms of what we plan to do in the community. I've got a couple of questions already. I met with Dale as well virtually, and I'm planning to attend the planning meetings in the future as well. I haven't been able to attend one yet, but I think there's one coming up in a few weeks. As an observer, so I'm not. Just to sort of take part in that. A couple of questions related to it though. One was that, as I understand it, I think ophthalmology is opened up in my stag. Am I right? Or
they are there, and they're part of the ongoing workshops.
And it was mentioned on the slide. That's why I mentioned it. I was going to say that if you take that away once you put it there, that would probably have the opposite effect of good feelings. And the other one is just a commentary on in terms of the active travel plan. That really is, as has been pointed out, that's absolutely vital. And Kyra, as you probably know, if they have buses at all, they're lucky. Yeah, I think working with the local council and local authority is a really good idea, because they had a similar issue with another area within my state called my state park, and they put in a community bus in, which sort of goes every so often to sort of deal with people getting up and down the hill, because it's built on top of a hill, and the people can't get there. So yeah, active travel plan I think is vital for this. And you said about the car park already, so I won't mention that.
That's it. Get it.
Yeah, thanks. So just being on the ophthalmology point, we're actually increasing the amount of ophthalmology we provide up there.
Yeah.
So it's a glaucoma hub for us. I guess the bit
in a flexible room.
Yes. No. The bit for me is, so this is brilliant, and we know we need to expand the building, redevelop it. We also know that there's a 20-year life expectancy differential in the south of Bridgend to the north of Bridgend County. So, if you live in Cairo, you will on average die 20 years earlier than if you live in Portsmouth. And I guess the question for me is, this is great, and this is going to provide some services which will help that. The bit that we need to run alongside this is that whole engagement with the local population on what they can do differently as well, and how we can help them to do that. And so there's something for me about, we mustn't miss the opportunity now of talking about a lovely big building that's going to be great and do all these things, but we need to start engaging with that community. And so I guess for me, what I want to see running alongside this is that public health campaign piece about how we begin to help that population close that gap, because it's not right. And I guess that's the piece I'm seeing.
Just I bring Paul in now, but obviously when Dale went through the slides, there were a range of third sector organisations who could be partners in this, who will make use of the space. And maybe we ought to set up some expectations at Health Board that organisations who are working with us and will be delivering services in that space also sign up to supporting our work in that public health ambition, because as we know, through our CTM 2030 leaders meetings, our third sector community-based organisations have great reach. Well, we need these organisations to help us convey and support those messages, help signpost people, help address those issues of well-being. So, maybe we should set that out as an expectation that yes, you can be part of this, but the ask that we place on you is that you support this public health agenda, because Gethin's right, that it's got to run alongside it.
It's absolutely important that we don't just think that the answer is more NHS type facilities, and that builds that dependency, which we will actively try and sort of shift. I should also say there is a lot of work already underway in the North Bridgend patch with the GP practice up in Cairo, and public health colleagues are working actively with practice up there on the wider health inequalities conversation. And there is also a project called the Deep End Project, which is a programme of work looking at how primary care can be more outward facing in some of the most deprived communities across the whole of the UK. It's a UK wide, and the practices up in North Bridgend are part of that. The other thing I'm just thinking, just on that point, Gethin, Rachel and Linda and I were part of a conversation with Philip the other day around some learning from other parts of the UK who've implemented the community health worker type of model, where you actually have people from the communities going around and almost like being given about 1,000 households to look after, and they actually are people from that community who go around and basically do health promotion, advice activities, get to know the community, talk to people about screening, about health promotion, prevention, signposting. That could be another thing, to your point, Gethin, alongside this, as well as the facility. We talk about some targeted, in some of the most deprived communities in that patch, of how those sorts of models might sit alongside the development of the facility as well. So I think there's lots of stuff going on. So I think it's how we bring it all together under that umbrella.
Thanks. Rob, Suzanne, and then Hal.
Yeah, just going to flag up the work I think Vicky Wallace is leading in Linda's team to sort of come to have offer, which is sort of come to have a kind of offer. So I guess it's
nice knowing you.
Yeah, but it's very much about that sort of joint relationship between communities and our sort of anchor institutions. And I think, you know, we can link that in with the MyStake work. You know, it's already on the front foot because it's built by the community for that sort of form bias approach. But yeah, I think that's a great opportunity.
Suzanne?
Yeah, I was just going to add really about the, you know, playing the digital flag, that a lot of these sort of joint services are highly dependent on being able to share information across the health social care boundary, and with the re-procurements of the national systems, you know, starting now in terms of mental health, community nursing, social care, we need to somehow incorporate, you know, centres like this into those discussions, because I don't think they are at the moment. And we already know about the challenges already with the previous system, or the current system, which has tried to share information on and be a joint system for health and social care and community workers. So I think that's a huge challenge. And, you know, there was a mention of digital services and utilising, you know, there's a huge opportunity for digital in this space in terms of how we reach parts of our population. So it's how do we, and we know that digital doesn't come cheap. So it's how do we, you know, incorporate that sort of investment and not losing the fact that we're going to need digital tools, digital things to support the community, as well as, you know, the resources and people, because that's how we will work differently, is through technology. So yeah,
I mean, that's just say, so Steve McDonald from
has
been appointed our point person from digital IT team. So we had conversations this week, and they will roll on through this workshop requirements and development, including those very conversations. It's not just the nuts and bolts of server rooms and IT equipment, but actually what does the digital offer as a whole look like as part of this development, and obviously stretching beyond the boundaries of the development as well.
Can I just make a comment on these, which is that we need to do some of this now, not wait until.
Yes, absolutely. Yeah, 100%. How?
Just on that broader population health bit, I was just going to mention, I guess, our ability to look beyond health in influencing what is the economic future of valleys communities that were previously thriving industrial towns. You know, there's a big transport strategy for Wales happening at the moment. How does that link in? You know, there's loads of opportunities there, unemployment, housing, all of that. So I guess it's sometimes I think we have these conversations from our lens, but there's a broader lens then with government and local government colleagues to look at the broader economics of our communities.
Thanks. Any other questions or comments? Dale, I mean, we've been asked to note the report. I think you get from the sense of the conversation and the comments that there's a huge amount of support for the work that's been done. And obviously there'll be those things that we'll need to come back to forward at a future point for sign off. But it's really great to see the progress, and notwithstanding there are the challenges of making sure that, you know, the financial side of things is nailed for government, but the fact you're keeping officials appraised, I think, is the right thing to do, because we do not want colleagues in Welsh Government suddenly being shocked at receiving, you know, a joint case that suddenly, you know, blows the budget out of the water that they weren't aware of. But, you know, clearly keeping people involved is really important. So thanks for the update. Yeah, good to see you. Thank you much indeed. Okay, we are going to take a 10-minute break. That's 13 minutes actually. If we can come back at where are we? 10:02. Sorry, 11:50. Just a second.
You're live, Jonathan.
Okay, well, welcome back. We'll now move to item 5.5.1, which is the Public Services Board update. And I'm going to Philip for this one.
Thank you very much. I'll keep this very brief, Chair. As people are aware, we're very much involved with the Public Service Board as a public sector organisation. They have a number of projects currently underway. One I'd like to highlight, obviously, is the active travel charter. They're also being involved with us with regards to the climate change work that Linda is leading as well. Clearly, there's lots to do in the space of the Public Service Board, and there is a need for leadership from the Health Board with regards to the work that they're doing. They're also doing a lot of work with regards to involvement and inclusion. So they've got a Young Voices programme, collaboration, and they're also updating their website as well. What's critical, right, is that we don't just limp from needs assessment to wellbeing plan with nothing in between, going back to a needs assessment again. So it's an opportunity within the Public Service Board for public service organisations to come together and identify what's really needed for the population. But clearly it's contingent on the involvement of organisations within it as well. So I will pause there, Chair, if there's any questions or comments. Thank you, Philip. Linda.
Since you mentioned the climate change risk assessment, the joint work, which I am involved in the PSB, it actually could be one of those areas where we actually get quite practical. And I've sort of, through this process, tweaked, for instance, that the local authorities, not our social care teams, but other parts of the local authority, have a good understanding of the climate change risks in their area and the very sort of hyper-local events that could happen, like the flooding of a road and restricting access and therefore restricting our services, which we're not keyed into at the moment. So, and I think there is something about this space that we could make more practical by making those sorts of connections and building into our community. So, for instance, building into our community teams, emergency or business continuity planning. Well, what do we do if that road gets flooded, which is going to happen twice a year in 5 years' time? You know, being more, yeah.
Absolutely, and I mean, obviously it's underpinned by the Wellbeing of Future Generations Act, and there's a very almost ideological aspirational component to the PSB in terms of what it wants to achieve in terms of changing the way that public services work. But I think it is critical as well that we still keep to our knitting and we do those practical things that are actually going to make a difference in people's lives.
Okay, thank you for the report. Any questions to Philip on the work of the PSB and our engagement with the board? No? Okay, thank you. We'll note the report. Regional Partnership Board update. Linda, I think this is for you.
Yes, it is. Thank you. I'm going to be quick as well. This is those of you on PHP. This is the same report that went there. But it's a good thing to be more visible for the whole board in terms of the activities of the RPB. So essentially, the report is a very high level. We can provide any more detail that people want. Principally on the revenue side, how we deploy the Regional Integration Fund, and you'll be aware that a lot of this fund, the lion's share of it, goes to our at-home services. So these are the integrated services that are at the front door of EDs to turn people around, and those that support people in those first few weeks after they've been in hospital. Really critical for the health service flow, and we're grateful that that's how this fund is continuing to be deployed. because we've been in trouble without it. But of course, it sets up a bit of a dilemma because we want to be able to spend more on children's services. And I'm glad to say that we have been able to move 400,000 out of there and into children's services as a sort of indication of the direction that we want to go in. But you know, we have to be able to do that without risking the rest of the system balance. The second part of the report is an update around how this year, or last year, the capital, the ICRF and Housing with Care Fund has been deployed. Very different types of schemes, mostly because that was the first year of the first year that the scheme was fully implemented, and it was difficult to then bring big schemes on. Mostly these are small units that have been uploaded for residential services. So I have to take any questions, but that's what it was.
Thank you, Paul. And then I was just reflecting on the capital schemes then, and I mean, all of which are really valid, I know, but just reflecting on the dementia conversation we had this morning.
Yeah.
You know, I guess there's that point going back to the needs assessment and the commissioning. What's it called? The piece of work that was done.
The market
sustainability report.
Yes.
Yeah, I guess it's how we make sure that is guiding, and it's tension, isn't it? Because there's always competing demands on the resources, but we know we have got some big gaps in some of our particular client groups, and it's kind of that's helping guide some of the investment decisions.
And that's a very live conversation within the RPB, and we're seeking a report both on that within the next meeting. So.
Okay, thank you. Any questions, Patsy? Obviously, thank you.
Yeah, just a quick one there. It's useful seeing how many people are helped with this money, the 35,000, just over. Is the money recurrent, or is it a pot of money that is recurrently there and used for the same thing every year?
Correct.
Or...
The latter,
yeah.
Which of course, when you get past January, just at the very peak of when we need these services, staff start to look for alternative jobs because the funding, it does roll over every year, but on a non-recurrent basis, you wouldn't choose to start from here, as they say.
And just to be clear, we're funding core health provision in the community with this money. This isn't an add-on on top of the existing. So let's be really clear. The health board is currently carrying a risk that a large part of our community services is currently funded in partnership funding, which is it's a good way to spend the money, but it does make you reflect on the other question about how we shift resources around out the system. We've perhaps, you could argue, we double run using this money, but how are we then making the shift in other parts of our system to reallocate resource to make that system? Because perhaps a question we need to ask ourselves down the line, linked to the strategy work.
Yeah, and I think certainly when it comes to how this funding was first designed, I mean, I've been around long enough to remember what was then called the Intermediate Care Fund, which was the first funding part the Welsh Government identified, Lisa, probably about 12 years ago plus now, I think. And it was around there somewhere, wasn't it? I think it was, yeah. It was a bit further back than that. And the whole idea, though, was it was about pump priming things. It wasn't about mainstreaming. It wasn't just about delivering stuff that organisations really ought to get on. It was about proof of concept, delivering new projects, seeing what worked, assessing it, and then saying, well, there we are. Then you should now take this on as organisations. But I think we've been collectively less able to do that for a variety of reasons. But I think, that then also imports fragility into the system, because there's always a risk that if those resources are modified in the future, fairly mainstream work which has been delivered by the RPB could fall by the wayside, and that's not a sensible position for us to be in. Sorry, who's Kath and then Rachel?
Yeah, I was going to say something similar really around. I mean, I just think the films are great, and it's really good to have those links and to actually watch the films around care and repair, and the home from hospital discharge project, etc. But I was going to ask the same thing really around how do we mainstream things that we know are really essential for our services and making a real difference, and do we need to be talking to Welsh Government about how we can try and mainstream some of these things, which will then free up funding for newer projects and different types of projects. So
yeah, and I suppose following on from Kath's point about and Paul's earlier point about trying to, you know, if we wanted to introduce sort of community health and wellbeing workers, as we've been exploring, then the RPB RIF funding is the perfect way of doing that, because it's meant to be used for pilot projects, you know, test new ways of working, but there just isn't enough wriggle room in that budget, as Linda has said, because so much of it is going on the kind of core activities. And so there has to be a shift at some point from Welsh Government's point of view to understand that, you know, if they said, right, from next year, there is no more continuation of services that have been using this money for the last 5 years, then, you know, some of our services, the health board, will be at serious risk. And so if we were then asked to provide another balanced budget, we probably wouldn't, you know, be able to do that if we wanted to continue those services. So it's really, really risky, I think, right across the board in terms of how we are relying on that money to continue to do our core work, but also the inability that we have and other partners around the partnership board table have to innovate. And you know, that's what we really, really need as a matter of urgency, is to take those examples like in North Wales that we know worked, but it was funded through probably ICF to start with, and then ICF ran out. And so even though it was working really, really well and making a huge difference, when the money ran out, the good work ran out. And I think, you know, that worries me that we haven't got a mechanism across Wales, I think, through this funding stream to continue the stuff that we know is making a difference.
Thanks, Rachel. Thank you. Okay. Any other comments or questions to Linda? Well, thank you. Okay, we'll note the report. Thanks, Linda. Moving on to item 6, our integrated performance dashboard. Part 1. I'll come to Linda again. Thanks. Thank you, Linda.
Actually, I'm going to hand straight over to my colleagues.
Are you fine?
I don't have anything to say about the
Nothing
actual
else to
report
say?
this time.
Fine. Okay, lovely. Gethin?
Yeah, thank you. I'm going to take the report as read, but just to write a couple of key things if I may. So in terms of mental health, just want to draw members' attention to the continued strong performance across all of our mental health metrics. We have got, you know, want to draw and let people know that we have had a period of quite significant pressure on our acute services to support we high volume, high acuity and high demand for our services. So our acute adult services have been under significant pressure, and that is being managed on a day-to-day basis, but remains a challenge. In terms of our urgent care performance, whilst there have been some improvements in the data, I think if it is set in the context of a continued period of very high pressure for our emergency services. We've heard from Carolyn around the concerns around boarding. We have seen delays in handovers over and above our level of tolerance over the last couple of months. We haven't been able to come out of any of our winter surge capacity, so we are still fully surged across all of our acute sites. And you know, we do have probably the second highest in Wales level of clinically optimised for discharge patients. So we are sitting at around 330 patients across our bed base, which we've already touched on, but that is then having a significant impact. Again, linked to that pressure, some improvement in our stroke metrics in month. I think it's fair to say that which is great. Lauren and myself are not necessarily fully assured that that's a sustainable position. So what Lauren and I have instigated now is a very focused performance enhancement group for stroke, really trying to provide some of that executive support and decision making around some of the key operational decisions we have to make regarding ring fencing of beds, making sure we've got really clear pathways for timely CT and thrombolysis. But the other piece is trying to move towards a virtual stroke directorate, because at the moment different elements of the pathway in stroke are managed within different care groups. And so what we're going to do is bring together stroke as a single stroke directorate, a virtual stroke directorate, to make sure that all bits of the pathway are working in tandem. from cancer performance, we had a good, much improved performance in cancer in month. We're seeing those longest waiting cohort continue to reduce, which again is positive. There's a lot of effort going on into cancer services on that specialty by specialty basis, which we discussed previously. I think diagnostics is a really positive story for us as a health board. So we are seeing the NOUS and the non-obstetric ultrasound numbers continue to reduce. We were at 9,000 patients over 8 weeks. That number is now down to several hundred, which is really positive. We've had the mobile MR scanner running now on LHP side. That's done over 400 additional MRs in the first month of operation. So again, we will see the MR position come into compliance with the 8-week standard probably over the next couple of months, which is really positive. So our main areas of focus are CT scanning, and that will be the next area of temporary support we will look to put in place. We have got a plan for cardiac diagnostics for our echoes. So that again will be coming down to compliance with our 8 weeks standard over the next few months. Similar position for urology, for cystoscopy, which is the bladder investigations. Again, a clear plan from the K group on delivering that. Neurophysiology, which is a concern, and we're working with Cardiff, who are a provider of a lot of our neurological and neurophysiology services on that. I do just want to flag GI endoscopy. So this time last year, we had over 5,000 patients waiting on our GI endoscopy waiting list. We were really concerned about that position. That whole waiting list figure now is down to 790 patients. So, a significant reduction, which just over 300 were waiting over 8 weeks. So we've seen a massive reduction in the cohort of patients, and we know that patients with cancer will be in those cohorts. As per our conversation earlier around LHP, our focus has to be to get endoscopy waits down to around 2 weeks if we're really to meet and diagnose patients in a timely way. Again, our therapy performance has improved. There's been a real focus from a dietetics perspective on our children's weights in dietetics. They've come down very significantly. You will also note that due to counting and changes mandated by Welsh Government, our weight management service is no longer in those reportable numbers for that return, which is what has driven a large change in our performance compliance. We continue to report that internally and focus on that performance. And then planned care, I won't dwell on planned care very much, but again, we did achieve 97.8% against the 99% target at year end, and I'll pick up that as in the presentation I'm due to do shortly.
The colleagues happy for us to go through colleagues on the exec team first in terms of the update, and then come back to different questions on different aspects at the end. Okay, great. I just want to just take Greg, Lauren, and Sally in terms of the quality section report. Greg, I'll come to you first.
Yeah, thank you. Just want to flag some of the IP&C metrics, which is on page 31 for 210. So out of the 5 IP&C tier 1 stretch targets for 23-24, we achieved the Pseudomonas target, so just the one, although we were second lowest rates of C. difficile across the whole of Wales. And we saw an improved rate in our MSSA bacteremias compared to last year. I think the big focus on C. diff last year was generally around antimicrobial stewardship, reducing PPI, so protein pump inhibitors, and a big focus on cleaning, so the deep cleaning of our wards, which can be really challenging when we have 2, 3, sometimes 4 extra patients within the bay. So the wards can appear really cluttered. Got something landed, maybe. So big focus on C. diff last year. From an MRSA and Klebsiella perspective, we're in the middle of the pack, 3rd lowest rates across Wales, which is really positive. We're still work to do in that space. So the focus really this year, and I think I mentioned this the last time,
is around to continuing the work around reducing E. coli infections. So that's specifically around medical devices care, so catheter care, midline care, central line care. Generally in our high acute areas, we've still got some bacteremias associated to line care. Big focus this year on community primary care support, where we see the majority of our sourcing infections generally in people's own homes or some care, residential or care home environments. The Quality and Safety Committee approved our IP&C strategy. It's in the consent agenda today. So that gives us a real opportunity to really change the shape of how we deliver IP&C services. With a big focus this year on changing the configuration of our specialty nurse services out in the community. So very disappointingly though, we started to see a bit of a dip in hand washing compliance opportunities in some professional groups. So I have asked the team to increase some of the audit activity, and we need to be better at challenging in the moment. So if we're out on the wards and you see a professional pick up some notes or touch a patient and they're not washing their hands, then we need to be better at challenging, obviously respectively, but in the moment. So so we're going to refresh our hand washing campaign in that regard. That was it for me. Thank you for my big chair.
Thank you, Greg.
And the background noise.
It's seeing whether fleets of helicopters overhead of us.
Sorry if I was shouting.
Lauren, thank you very much.
Thank you. Just a couple of brief points building on some of the things that Gethin raised. So, like we said, in terms of stroke, we've improved in 9 out of the 14 indicators this month, but it's the sustainability and the consistency of that that's our focus. We've had some good appointments into senior roles there, so a senior ops person for the overseeing the stroke services across all sites, and then also appointed into the CTM clinical director post. So that's translating into strengthened scrutiny in terms of we talked about the case studies and diving into the data and understanding the rationale behind our breaches. And I think it's also translated into improved quality of the narrative in the report, which hopefully you noted in terms of some of the detail and some of the rationale behind the performance. And we've also had an indication that there'll be an increased focus on stroke across Wales generally. So it's about us all improving our position across all of the health boards. In terms of psychological services in adult mental health, we've talked previously about some really successful recruitment drives that we've had. There was a wave of new referrals a couple of months back, so we'll start seeing the effect of those. But we've diversified the workforce, increased the capacity, so it's not just clinical psychologists we've recruited into. We've got counselling psychologists, psychological practitioners, and the clinical associates in applied psychology. So that skill mix will have an impact. And then, as Gethin said, from a therapies point of view, significant work has been done across adult and children's services, looking at waiting lists, and there's that consistent looking at different models of care, different service delivery, which we're seeing the impact of, and upping our offer in terms of supporting people. That's it. Thank you.
Thank you. Sally, thank you.
Yes, not too much for me. Just on one point, on Greg's hand washing point, we are expecting the new medical psych leads to help that work, and hopefully that will bear fruit. Just want to highlight the mortality rates, which continue to be within expected levels, and indeed show a end of year decrease in those rates. And I think we have mentioned at board before how we have wanted to improve our data collection around mortality, and I'm pleased to say that a digital form has been developed and that has just started to be rolled out. So Yvonne and the bereavement team taking that on, and hopefully we'll have some more granular detail about mortality in the months to come. So that's all from me, and happy to take any questions.
Excellent. Okay, thank you. And I'll come to Hal next. Thank you.
Thank you. So I'm looking at page 27 and 37 on the performance report. So cautiously optimistic about some of these metrics, which seem to be going in the right direction. So sickness continues to very, very gradually tick down towards pre-pandemic levels, not quite there yet. But if you look at the graph on the top there, we've got 4 or 5 data points in a row heading downwards. And if you look at the front end of the graph, we're kind of normalizing from a period of instability in terms of sickness, which is positive. Similarly, nursing turnover, which has been a real issue for us over the last couple of years. We've got 8 data points now in a row downwards. So I think we can safely call that a trend. And we are now, again, at pre-pandemic levels around about 8.5%, which is really positive from a peak of around about 12%. So that's great. We've also got some significant work happening around retention. I'm not for a minute suggesting that reduction is due to that, because I think that's just normal variation at this point, but we have got some good work happening, which I would hope would further improve that. And then below that, we've got a very, very slow but steady increase in both staff demand training compliance level 1, which is I think at the highest level we've ever managed to get it, which is around about 79%. And also our PDRs, which continues to tick up. That was around about the sort of 45% mark a couple of years ago. That's now up at 65%. Of course, 35% of our colleagues not having a PDR is not where we want to be, but that steady increase is really positive. I should just balance all of that. So that's really positive stuff. The reduction in turnover, particularly in terms of our vacancy rate and some of the efforts we make. And sickness coming down is also positive, but we also know from staff survey, wellbeing survey, that we get a significant level of burnout and overall stress and wellbeing issues within our workforce. So we can't assume from these that we cracked it. We've got to continue to make efforts, particularly in the strategic workforce planning space, which is why the conversations we're having with HEIW and shared services and government colleagues around pipelines and overseas recruitment are so important, just to reduce that level of overall pressure within the workforce. But make no mistake about it, reducing turnover and sickness will certainly contribute to that positively.
Thanks, Phil. Before I throw it up to questions, can I just get in and come back to you on one point? Yeah. We submitted our draft IMTP before the end of March, and that part of the basis, part of the planning assumption would have been the targets for improvement that Welsh Government had set for all health boards for this year. Yes. Since that was submitted, Welsh Government have now varied that trajectory. They've varied the target required. How are we now factoring that into what we were planning for this year?
So we have got our revised plans, and I'll be taking you through those imminently. But yes, so the changes are that it is to have no patients waiting over 104 weeks for their RTT position by December this year. That no patients would have waited over 3 years by the end of August this year, and that by the end of March 25, no patient would wait over 52 weeks for their first outpatient. Yeah. So I will take you through where we are at the moment on our planning and where we think where are our key risk specialties and what are the productivity improvements that we're going to have to make in order to deliver that within the financial.
So just really quickly on the IMTP, is government expecting us to resubmit a?
Yesterday.
That was yesterday, is it? Right. Yeah.
The trajectory.
The trajectory.
Yeah, but I did, in the letter I wrote back to Mitwood about the IMTP, I did make the point that, you know, and this has come up through the chief exec group as well, and we had a letter we wrote to Judith to say, you know, the IMTPs were based on the previous performance ambitions, and clearly the financial performance associated with that was alongside the then performance trajectories. You now change the performance trajectories, then clearly that's going to the financial doability of some of those trajectories is going to be a bit challenging for some organisations, so or for all organisations. So it is an important point. I think probably as Gethin said later, we'll hear about where we think we can get to, but we probably will just need to highlight any of the risks that sit alongside that delivery. But you know, the ambition is very clearly articulated, or has been clearly articulated to all of us, that this is, you know, it's not a we'd like you to try and get there. It's we expect you to be there at that point of the year.
That's good. Okay. Ian?
I thought I was in the queue then. Surprised me. Yeah, I just wanted to comment on one thing. We had a digital agenda committee last week, and I always take an opportunity to bring up clinical coding. And this is such a good news story, and as I've said it before, but if we look at where we were in clinical coding in 2020, there's two measures there. One of them was number of episodes clinically coded. We were down at 40%. We're now at 95.7%. And we're on the other one, correcting errors in coding, we were down at 70%. We're now at 94.7%. And that was because of what our own team has done in terms of developing specialized software to enable them to do that. Because there's been a national problem with clinical coding, as people know, in terms of recruitment and availability of staff. But this AI system they developed as improved that position. What I'm going to comment on, though, without sort of background information, which people are probably aware of, is the fact that the team now would potentially have another staffing crisis in a year or so, because very senior staff are due to retire. So they're now going about training a new team of trainees, if you like, and training them with the ability that they can actually write and rewrite the code that has been developed as well. I think we've been seen as an exemplar in Wales, and you know, I can't say enough about it. I mean, I'm really pleased with the way the team has taken us forward. So just a comment. There we are. Well, I've had the opportunity to say that. Thanks.
You'll be pleased to know, Ian, that on the leadership board of NHS Wales this month, we talked about coding, and also some of the challenges, as you rightly said, coding is a really specialist function within the health board, and the problem we've got in Wales is it's the sort of job also you don't have to be on site to do, you can do remotely. So a number of our coders in Wales are being poached to go and work for trusts in England remotely because they're offering higher salaries. So part of the conversation was, what can we do to grow and keep our own coders in Wales? So there's discussions at DHW Healthy Coordinate around developing some sort of skills academy for coding in Wales to try and help grow people, but also, as you say, the automation and AI technologies that we are very much at the leading edge of were highlighted as really good practice, and it's really positive. I know our coding team have given some feedback into the national programme around this, so you're absolutely right to highlight it. It's a really important part of what we do. But you're also right that there is a real risk, not just for us in CTM, but across Wales, that these sorts of very specialist functions can end up disappearing. So I think personally it's a really good opportunity for some of our, when we talk about, you know, routes to employment for apprenticeships and those sorts of things, there will be people out there that wouldn't even know that sort of role existed in a health board, but might be quite data driven or interested in data and analytical stuff. It would be a really great opportunity for us to think maybe back to the colleges, the university, about how we might want to sort of develop some of those sorts of things locally to try and bring on the next generation of people who will probably be a very different type of coding skill set to the ones we had in the past.
So Patsy and then Nicola.
Just a few questions. On page 5, the weight in ED, is that an issue of staff numbers or staff skill mix or space? My first question, or all three. On page 6 and page 8, the index colonoscopy, and I know I've raised this before, and I think we were going to see something through quality and safety about the consequence of it. Not sure I've seen that. Apologies if it's been through and I've missed it. But my main question on that is page 8 states under the detail of that headline figure of only meeting 8.4%, that 50% of patients refuse their first appointment for the colonoscopy. And I wonder if they are excluded, therefore, from the headline figure of 8.4, or if they're included and therefore that inevitably will make it 50% worse.
Yes.
So, okay. On that colonoscopy, it talks about a third room being planned with a move date of 17th of May. Just wonder if that's additional capacity or if that's just a movement of capacity. On page 15, this is a quick one, on the ambulance performance, it talks about a meeting that took place on the 10th of April, and I wonder when we would see the outcome of that meeting. That was about multi-agency discharge events that links back to conversation earlier. And finally on stroke, can't not mention stroke. Looks to me like the once it for the patients that have been diagnosed, all of the indicators are improving. That's the way I read it. But it's that bit of diagnosis and particularly at POW. So I wonder if the new recruits that we've heard about this morning will help with that.
Yeah, so weights in ED are an element of all three of those. So there's both in terms of surgeon numbers. So we will see a large number of patients arrive in a very short window of time. Clearly, if we don't have spaces in which to see and assess those patients, that creates further delay. And our workforce numbers on one site in particular, there's a lot of work going on around aligning the workforce capacity to the demand profile, because it's not quite in the level of alignment that we would want. So that's one of the actions that's going on. I think in terms of triage, and this is where I guess from a safeguard perspective, our triage performance is good. So we are very good at triaging patients in a timely way within our compliance with the 15-minute standard on average pretty good, decent. So that means at least we're identifying the sick patients and pulling those through in a very timely way, and that those patients that are waiting the longest to be assessed by a doctor are those whose clinical need is the least urgent. There is a specific issue again on one of the sites of the type of patients that are attending. So one site in particular has a high level of primary care orientated attendances, and so we're looking at what the right workforce model is for that site, which might include increased GP time, because we know when we have put GPs into that site, the waiting time has been managed more effectively in that way. So that's, I guess, those. In terms of the bowel screening, Wales colonoscopy. So on now, we are probably one of the highest performing health boards in Wales in terms of the timeliness of patients coming through for colon. So we are scoping those patients probably 80 to 90% of the time within the allocated window. So there is an issue, I think, with the data that we need to go back around to make sure, because the data that we're reporting on in terms of from the point of referral for a colon to them being offered that for their date is now significantly up, and as I say, our performance is now one of the best in Wales on that. The third room was we've moved from the old endoscopy unit to the new endoscopy unit at Prince Charles, which has a third room, and that is additional capacity because we still have the mobile machine here in Royal Glamorgan. So it's all part of the plan to bring the waiting time down. So that is additional capacity being provided now at Prince Charles. And then the MAID event, so that is a multi-agency discharge event, that was done at Princess of Wales Hospital. So the report is now in, it's going through internal governance around that. So we'll bring that, I'm happy to bring that back to a quality and safety or PPF committee in the next round so that you can see the learning, but some really helpful learning and identification of some good practice.
That's good. Thank you. Patty, sorry, Nicola.
Thank you, Jeff. My question is on page 7 around our childhood immunisations. We are CTM and CTE historically had really good compliance with immunisations. We are really struggling now, and if we look back over the last 4 board meetings, I think the challenges and the actions are very much the same, and they're very focused on what we can do as a health board. But what I'm not seeing through any of it is, how are we engaging with our population to find out what are the barriers they have in attending where we are offering immunisations? Because if we don't know that, we can't help them overcome it, and we're at risk of putting time, resources, and we know we have issues within our public health services to areas that are not making a difference. So we need to know what are the barriers our public are facing in coming for these immunisations. to help us make sure we're immunising in the right places and at the right times. So it just would be helpful to see through there somewhere, how are we engaging with them, not just what are you doing internally.
I'll speak up tonight. Yeah, so we've got the vaccine equity strategy that's being produced, and then clearly we're aware that we are not meeting the targets currently. We are doing work in terms of behavioural insights to understand what, as you say, what the barriers are. We've also had approval to recruit into the vaccination team as well. So I mean, there's two sides of it, isn't it? There's the supply and the demand almost. But I take your point on board. I mean, the vaccine equity strategy, which I'm happy to share with you. I mean, it outlines the actions that we will take. We made the decision not to just say, okay, by next year we will be meeting the targets. We're doing it in a staged manner to be realistic in terms of what we can achieve. And there is work going on in terms of tackling vaccine hesitancy, especially that's being pushed online in terms of social media. We're not alone in this, though. We're challenged in terms of we are not. CTM is still performing highly compared to other health boards in Wales with regards to vaccination, and we are seeing increased reluctance post-COVID across the board, but there isn't an easy solution to it. I take on board what you're saying.
If I can just, I appreciate all of that, but you know, we have a vaccine group that meets monthly. I mean, what's the outputs from the vaccine groups? And I think a strategy is great, but our people, our families out there, a strategy means nothing to them.
Absolutely.
So we need to be engaging with them to find out what are the barriers, how can we best serve you, you know, and overcome the issues that you're having to increase back to where we were.
Well, a couple of things that I mean, absolutely, I agree, Nicola, and I think there's something that clearly people like our health visitors and GPs and others are really key to getting some of those messages across. But I think it also highlights, as Philip says, there are some of our communities where we are dealing with some quite challenging vaccine hesitancy issues, and I think that has become greater since COVID. I think more and more people are now querying about vaccination just generally about it, so we just need to think about that. And I think, as Philip said, you know, the group that's working on that needs to be picking that up. I think also on the school age children, I know Greg's already met, haven't you, Greg, with the 3 directors of education for the 3 local authorities to talk about the school nursing provision and what that needs to look like in the future, because I think we'll all acknowledge the school nursing provision for the future is very different to what it used to be in the old traditional school nursing perspectives, and I think the directors of education have been raising that for a while now. So I think we've got a bit of a plan of how we're going to work with the 3 local authority directors of education on school nursing and what the role of that is in the future. So I think that's part of it. I also just come back to the point, and I bang on John about this but the conversation we had with Rachel and Linda about these community health workers. Part of that type of approach is having trusted individuals in your community who aren't necessarily professional, because frankly, even health visitors and others in our communities aren't necessarily always going to be trusted. So actually, but having somebody whom they know down the road who can go and have a chat and say, oh, you know, you do need to get your kids vaccinated for these things because this is what happens if you don't. And maybe also the measles challenge we've got going on at the moment highlights to people, if you don't have vaccinations for some of these key things, this is what happens. We start to see resurgence in diseases that largely we didn't see because people are vaccinated against them. So I think that is another example of how we need to be thinking perhaps a bit differently about types of roles in our communities to help promote some of these really important public health messages.
Absolutely, and I mean, measles is a good case in point. Really, we know, especially the second MMR, that there's been lower uptake. So we are, for instance, going into schools where we know that there is low uptake in order to take the service to people directly, as well as working with our staff group as well and pushing to vaccinate staff. There's been a number of Welsh Health circulars. For instance, there's new vaccines being introduced, and we know from feedback that people don't understand what RSV is versus COVID versus X, Y, and Z. And so what they hear is we want to inject you again, and then there is reluctance to that. But I take on board that there's a lot of work to do in terms of engaging the community. Yes.
Lisa.
Linked to the vaccine conversation, so I mean, disappointing that Merthyr was sort of lowest of the three, local authorities. But linked to Greg having that conversation with the Directors of Education, certainly in Merthyr, we've got the community focused school projects where they're linking in with local people, goes back to their community workers. We're doing some really positive work in Merthyr from social services point of view, working with the community focused schools to look at prevention. So there's no reason why vaccines can be built into that. So I think that's probably something we can do as a real positive action to take that forward to promote the vaccines. But equally, sort of looking at the sort of the CAMS data and some of that, the new developmental work, rather than health, be looking at the waiting list. Is this something we can do together with education, social care staff? Because there are some people who are waiting for 6 months for assessment. In reality, do they need a CAMS service? They might need, behavioural support, some prevention work. That helps, from the waiting list point of view. There's some, investment going into that area through the children's board, through RKB, and Linda touched on some additional monies for children. And that's something we can look at. We can do that together. And I think, looking at the data, I think it's not about health. It's about what we do together. I think it's a clear message.
Thanks, Nick. That's really helpful. Laura?
Yeah, just coming back to the point around stroke vaccine. That's okay. We're not moving on the conversation. So yes, the new people in post have got the pan CTM view, so their focus is absolutely bringing up performance in line across both sides. I guess it's worth just flagging that the variation that we can't rule out currently between the sites is when people present. So if they present out of hours, in terms of, once they've had a diagnosis, that follow-up input from the therapies team, for example. If they present out of hours, then we can't meet that target, and that we do see some variation month on month between sites as well. But yes, alignment across the pieces, the focus. Yeah.
Thanks, Lauren. Okay, any other questions to the team or any comments on data? No? Okay, well, thanks. We'll look the report. We move on to the finance item under 6.2. We've got the first report, which is our month 12 position. There's a further report, which is our month 1 position, and then we'll have a capital update as well. So, Sally, thank you.
Okay, so I'll sort of concentrate on the capital bit, which probably got more in there, but in terms of month 12, clearly subject to audit because we've now submitted the draft accounts, and we'll go through that. So we reported a surplus of 0.1 of a million, which is against a 1.5 billion pound spend. So in terms of capital, we reported a 33k below CRL against a spend of 75.7 million. And that was lots of additional funds coming out towards the year end. So, a huge amount of work by the team. Cash, 1.4 million, slightly, that seems very low, but we do draw down cash according to need. It's been a worry all year, but that's where our position is for the year. So hopefully the audit will be smooth. We'll keep everything crossed and we'll be able to maintain that position. Month 1 was a difficult month 1. So as you know, we submitted our plan, didn't we, at break even, but with risk of around 9.5 million. The risks that have emerged or crystallised in month 1 have largely been about cost improvement non-delivery, and then some operational variances. Gethin and I are in the process of working through with all the care groups their month 1 positions and looking at how we can improve that. We've maintained our forecast break-even position for the year, and that's against a spend of a roughly 1.5 billion again. We'll expect to see some of the allocations come through that will increase that as we finally get the finalised position around pay awards, both for last year and for this year, when that comes through. Capital will report in the main reports from month 2 onwards, and I'm not sure whether what the announcements have been, but there is expected to be some additional allocations around backlog for the estate, which we are being sort of brought together from the previous submissions we've made, and we expect to get some feedback fairly soon. We need it fairly soon because clearly there's a lot of expenditure here and the teams need to deliver it in the year, but that is or will be positive news, hopefully. So shall I pause to see if anyone's got any questions on those two?
Yeah. Thanks. Kath?
Yeah, just to say massive well done to you and the team for landing the jumbo jet. Yeah. I just think that's really great. Just to clarify in terms of savings, so we made, I think, like £27 million worth of savings last year, which is fantastic. I mean, on top of that, though, we've got to make a further, is it 23 million or 26 million this year? I wasn't so sure. 23 million this year. Okay, for the whole year, of which month one we are down on, but we're going to catch up, and you're going to get in and make the magic getting around. So trying to.
So we've been reviewing in profile, reviewing in detail to look at where schemes perhaps won't deliver, but what alternative schemes might be able to be brought in. Because we've now moved back from the control total approach to a budget approach, because we put the £44 million out into budgets with the new money, that allows us to go back to the discipline of recording all our savings via the ledger.
Right.
So we're probably being stricter as we go through this year in terms of how it gets described and when we can identify them. So, for example, if you look at prescribing, primary care prescribing, that always runs 2 months in arrears in terms of the data.
Yeah.
So we won't be able to be certain about any of those until probably, month 4. So there's a lot of working through, but trying to make sure we've got that discipline of working it through the ledger so that it can all be tracked through.
Yeah. Well, I mean, just a reflection, I guess, on last year. I mean, this has been a really challenging position to get to, and it's really positive. And I constantly say this as well, you can't underestimate the confidence that delivering the financial position gives, and just gives a bit of, means that we're not completely being chased every 5 minutes about the financial position, which does give us room to then focus on some of the other things that we want to do. Having said that, it has also meant some really difficult choices as well for everybody, and we know that there are things that we would like to invest in that we haven't been able to invest in because we've needed to get the financial position back in to a better place. And hopefully if we get this year's delivered, it puts us in an even better place again for next financial year, where we can start to look then at a bit more latitude around some of the investment choices we'd like to make. Just also wanted to highlight, we have made some good progress in some of those big ticket things. So the nursing, I think we need to highlight, the nursing agency and temporary staff spend has come down considerably in the past 12 months. And I think, how reflected on the turnover, that is also all these things start to show you a picture, don't they, of how we are starting to get a better handle on our staffing in the nursing workforce, where we've seen that agency spend come down. We also got the new rate card being launched imminently for the medical staff as well, which will be one consistent rate card for the whole of the consultant workforce, adding to the existing card that we've already got for non-consultant grade staff. So I think, the workforce, given that 70% of our budget is spent on workforce, if we can get those sorts of big ticket things into a better place and better controlled, it does play a big part in our savings delivery, because a large part of our overspend is driven by temporary staff costs. And so if we get the temporary staff, we can focus on that. That's one thing. The other thing I'd say is there are a couple of areas where we have got some risk it's worth flagging. One of which is the overseas international recruitment, where we asked Welsh Government for you remember when we were talking about the IMTP for this year, we said that we wouldn't budget for that ourselves because there was money potentially coming from Welsh Government. The money that has been allocated from Welsh Government is about 50% of what we actually asked for, and has come with a whole string of caveats which were not particularly helpful. So we have raised with Welsh Government that the supposed latitude that we would have as an organisation that balanced to be able to make some more flexible choices like this doesn't seem to be coming through in the way they're behaving. So we have raised that. And the second point is that Suzanne and Stu have been working up a case to submit to Welsh Government also for some of the money that's been held back for supporting the transformation of back office services. And Suzanne's done a fantastic case which starts to articulate the opportunity for digitising a lot of our back office services, particularly relating to the whole process of appointment booking, handling of appointments, all of that stuff, which is still a very, very manual, labour intensive process. just going to throw this out. This Dan would hate me for doing it, but I told the minister it last week, so I'm sorry. So we have 1,100 staff at the moment in admin and clerical jobs, managing the booking and processes that go with booking of appointments. That's about £32 million a year in cost. So the opportunity to make some really big improvements in that area, not just in terms of efficiency, but also most importantly to improve the experience for our patients. We're spending all that money at the moment, and even today the experience for our patients isn't great because people don't get their letters on time, they can't chase their appointments online. So there is a big opportunity for us if we can get some resource to fund project capacity this year to start a big programme of work on that. And that's something that Welsh Government are also really keen to prioritise. It's been mentioned on the planning guidance. It's been talked about quite actively in the value and effectiveness groups nationally. So I think there are two big areas where we have opportunity, but there is risk that if the money doesn't follow from government, then we will not be able to realise that opportunity as much as we would like to in this year.
Any other questions, Sally, at this point? No? Okay.
Have a capital one?
Yeah, thank you.
So this report came to PPF previously. It is month 11. I didn't ask the team to update it to month 12 for this. A, because it hadn't been to the committee, and B, because they've been flat out trying to land all the schemes. So I think to flag it really is that we expended last year 75.7 million on capital. We had a relatively modest, I would call, discretionary allocation. So it's worth reminding people that the our discretionary allocation, which is what I call keeping the lights on capital, covers our digital backlog. It has to cover a lot of things. Was reduced by 25% 2 years ago and has come now back up to our previous spend, but still is sort of set at around 10 million. Which for the size of organisation and the number of, if you just think of the 3 acute sites, is very modest, is the only way I can describe it. On top of that, we've got a significant All Wales capital programme. The largest scheme is the Prince Charles Ground and First Floor, and that has been progressing over a number of years. That's a £220 million scheme. So you can see here all the different elements that made up that funding stream and the range of stuff that we've been doing within the capital programme. EFAB, just to highlight those ones, infrastructure, fire and decarbonisation. EFAB is the Estates Funding Advisory Board. That's a process by which we can prioritise schemes within those. The infrastructure really needs backlog maintenance. We fund up 30% from our discretionary funding, and they top it up to by 70%. But it looks like it's All Wales funding because they top slice it off and then give it back as All Wales. So it just skews the figure slightly when you're looking at the discretionary position. So there's a huge set of works going on there. It is a complex programme, and we have worked our way through it. In terms of the way we always manage the schemes is to overcommit each year. That's because some things don't start, some things are slower, things move around, and therefore we overcommit by that 13.5%, and then we manage to it as we come to the year end. And that means there's a huge amount of work for the team to deliver that. So in terms of the major capital schemes for the year, we have been running through the sort of major schemes which are in. I'm going to go to the back of the report. So the Appendix A sets them out. So PCH Ground on First Floor, that is the biggest capital programme in Wales, just so we're aware. 220 million approximately approved allocation. We spent another 50 odd million this year. It moved around slightly towards the year end because, as you can imagine, we have to do valuations at various points on this, and we're expected to spend another 75 million as it moves forward. It's a big complex scheme. We have used quite a lot of our contingency already in terms of where we are on it, because we keep finding more and more asbestos. It's one of those things about improving older buildings, as you find lots of unexpected things, and we have found more asbestos than you can believe. And obviously we've also had to use novel techniques to build some of this. So you'll have seen the piling that's gone in for all the kit to go on the roof. that has had to be done in a different way to a standard build because the ground contamination due to asbestos as well. So apparently people used to just carve it up and throw it out the window when they were building the hospital, hence why the ground is so contaminated as well. So it has some unique challenges, I think it's fair to say. The aim of it is to lift the fire enforcement notice, but it's also to address backlog and to improve the environment. And I think we can start to see some of the real benefits coming through now, but there's still a long way to go. And then there's phase 3 as well. So we've got some fees in at the moment for phase 3. There's more for this year in terms of the design. There are challenges around inflation and around some of what we've been quoted back around the scheme that will need to be managed as we go through. The aim, lift the fire enforcement notice and give us a functional environment, you know, with some improvements like the endoscopy suite. All still to work through in terms of the end of the scheme. You can see here some of the revised sort of dates as things are being handed over, and it is a testament to the staff on site as well, working in a building site, delivering a live hospital in a scheme of this size. It's incredibly challenging, and you know the operational team and the project team have to work together incredibly closely to make sure that this is still doable, and it is going to be a big challenge as we go on. So we've only got 2.4 million left of the contingency balance. That is making Welsh Government a bit nervous, but we are keeping, you know, that's something we keep under review very carefully. We've got a programme board that meets. I won't go into fluoroscopy because that's just something that's working through. Bridgend Health and Wellbeing Centre, aka Sunnyside. This is a scheme that was funded up at 10.7 million back in 2010. Unfortunately, then ran into a sort of series of problems which were largely associated with the contractor going out of business and then having to re-tender it. It has been re-tendered, a new contract has been signed, funding's uplifted to 19.2 million. And I think we are now starting to see that move forward, which is really good news, because it has been, you know, we are operating out of some fairly poor estate as we work on it. So works commencing 3rd of June is the aim. So that's been long in the planning. POW fire enforcement notice and theatres. People will be aware we had a very expensive sort of response originally to that scheme. We've been working to try to come up with something more sensible and doable, but that remains a challenge and a sort of to arrive at a scheme that we can deliver. Same with decentralised decontamination. We've now come up with a sort of alternative potential space that will need to be designed, but we will hopefully be able to move that forward during the year. Then obviously noted most day that we've heard about before, and then the estates infrastructure schemes. There's a lot of work going on there. It's probably just, I know we've touched, haven't we, on estates a couple of times and in terms of where we are. So excluding ground and first floor, at PCH from the figure, our assessed backlog is somewhere around 66 million. And our funding is clearly nowhere near that. So that will be an ongoing challenge that we will not be able to tackle, or can only tackle in stages, partly by refreshing our estate, by some of the infrastructure work and making sure we can get to this sort of as much opportunity from things like EFAB that we can, but there will be an ongoing challenge around the estate, that backlog, and needing to get it worked through. And then the other thing I just wanted to draw people's attention to is the capital prioritisation, which is in the main body of the report. This was something we were asked to submit to Welsh Government. We went through, worked it through our executive capital management group to pull through the schemes. It excludes the IRCF funding stream and DPIF, which is the digital funding stream, but we have flagged that in the correspondence as we went through. Obviously, the number there is significant across Wales. It's I think about 10 billion. The process from now on
is for Welsh Government to have a series of sort of groups who will look at what's there. They've got our risk registers, and they will tell us really whether things look possible or not. But that's not a funding agreement. That's a how we start to refine the programmes that we're going to put in. So it's a long way to go. We're expecting some feedback at the end of July.
Yeah.
So that really sort of just a whistle-stop tour of capital.
Thanks, Simon. A lot of ambition in there as well, so which is fantastic. But yeah, not without challenge risk.
Yeah, thank you. I think it's really great to have that overview around capital spend, because it really reinforces how little discretionary capital budget we have with the size of the organisation.
Absolutely.
How restricted we are, but also great that we've got capital funds going into Prince Charles. And when I went there, I was just absolutely bowled over by the amount of capital works going on, and we're running a hospital. So totally endorse kind of all of that. I guess looking forward into the future, you know, there isn't a lot of capital funds. Everybody wants capital funds. There's real demand for it. Have we got any innovative funding ideas that we can put to Welsh Government around recycling of capital receipts, or, you know, more private sector sort of loan funding, or anything we can do to sort of to really think outside the box on this?
So I suppose there's the rub around IFRS 16, and how that plays through, and what the capital regime will be for capital cover for those schemes. The only innovation that's being run at the moment is the MIMS project for Velindre, which has got a very complicated model that keeps it off balance sheet, but I think is quite costly in terms of the risk transfer, as lift PFIs were in the past. So at this point, there aren't very clear routes to innovation, but we will need to be clearer once we can understand what the IFRS 16 capital cover regime will be. That will help us balance some of those things up. And we also need to be able to think about how do we go forward. I noticed there were some questions at the Senate Public Accounts Committee around, did the Velindre MIMS model offer optimal value for money? The statement was it offered good value for money, but it won't ever be optimal because there are obviously margins within it. So I think we need to work with Welsh Government colleagues on what the business cases for those sorts of things will look like.
That's not cool. I mean, I just think on that point, there is good. I think this dual Wales bit of work to articulate the scale of issue is going to flag. There isn't an answer to the problem, frankly. There's no way there's going to be enough Welsh Government capital money to fund the backlog issues, let alone all the new developments. You know, bear in mind, we've got colleagues at Cardiff who are looking for a significant sum of money to refurb and rebuild UHW. At the moment, the money isn't there. You've got Howell Bar wanting to build a new hospital, the money isn't there. So there's going to have to be some answer. But as Sally rightly said, the challenge is there are alternative models, but the IFRS 16 regime now does bring some challenge into how those are actually accounted for, and then how the capital allocations need to be adjusted. So I think there's probably a wider UK government conversation that will need to be had about how they're going to handle it, because the NHS in England has similar scale of challenge in terms of backlog and pressure, and no immediate answers for that. So I think what we've got to try to do internally, and we've had a conversation internally about this, is where we can get out of buildings an estate that is suboptimal and we don't need it anymore. We need to accelerate that, because frankly we are equally occupying a number of sites across CTM which frankly are not really fit for purpose anymore. We need to get out of, because we can get them off our books and not have to pay backlog and heating and lighting and all that. So where we can, we need to get out. And we've also talked about whether there are opportunities as we get those receipts back to talk to Welsh Government about saying, can we reinvest some of that in things like digital transformation? Because we want to move away from buildings-based services to more digital services, but we don't have it's all coming out the same capital pot.
That's what I mean by the recycling of the capital.
I'm sure we all support that.
Sitting on assets. Can we sweat our assets more?
We are. I suppose I wouldn't be too optimistic about the size of those receipts. No. They tend to be fairly marginal.
Yeah.
And the sites have their own difficulties. So when you come to sell them, if you've got a estate that's got hidden asbestos or a large asbestos register, the valuation comes down. And most of our older sites are subject to those sorts of challenges. So there's a need to have a look at this. Everyone will be aware. So we don't have, according to all our surveys, RAC present within our estate, but clearly both across the rest of the UK and in Wales, is a new challenge that is sort of trumping fire enforcement notices at the moment in terms of risk. But there's huge risk out there, and the capital funding is never going to address the whole of it. And we know we just need to work on that. If you look at the capital prioritisation elements, probably just worth noting, one of the bigger amounts we've included is a very broad estimate around Princess of Wales, where we know that there are issues around compliance and around the roof condition and the condition of the estate generally. That when it came over to us, we've put a lot of money, over 20 million, into the estate there since we took it on. But there are still more challenges, and you can see that in the EFAB scheme as well, around the electrical infrastructure and other elements. So we included that to flag the size of the issue that we've got in terms of that estate.
Yeah, thanks.
Excellent. Okay, any other questions to Sally on these items? So just being asked to note the month 12 position, the month 1 position for this financial year, and to note the capital updates. And I just echo Paul's comments very quickly, and those others of thanks and congratulations. I recognise it is enormously challenging to attempt to hold the line, particularly around balancing the budget. We do spend an incredible amount of money, and it is right that we do what we can to bring that within budget in terms of matching our expenditure with our delivery. I know that's tough because it means that, you know, all too often we're looking at our ambition and our wish to spend money this year, and that constrains what we can do. That doesn't mean that we're not spending money, and it doesn't mean that we're not investing either. I mean, there are really good examples in here where money is being invested into services, and I think we ought to be perhaps clearer with the public about actually, whilst we are seeking to balance our budget this year, there are these exciting areas where we as a health board are investing our resources to improve, you know, the offer to our patients. And I recognise this causes difficulty, because I know, you know, we want to get things done quickly, but it means that as we go into the next financial year, it puts us in a very strong position indeed. And I think that, you know, we have to make that contribution to the wider sector, because I look at where we've been for the past 25 years. In 1999, we spent 40% of the Assembly budget on health. It's now 52%, and it has been growing and growing, and you get to a point at which, you know, it just becomes quite unsustainable. So I know this will be hard. I really accept and recognise and thank Sally and the team for the work that's been done, but all of the board, and in particular all of the exec team, for supporting this and understanding that this is difficult. There are really good reasons as to why bringing us into line is the right ambition. So thank you very much indeed. We are going to move on to the update from Gethin on getting it right first time. The productivity work that's been done by Gethin and the team. This has been part of a bigger conversation with Welsh Government, with ministers, with officials, around how do we maximise the use of our resources, particularly our theatre resources, in terms of trying to get through, you know, the level of work that we want to get done to get people treated more quickly. So this is a big piece of work. I know Gethin's been working flat out on this. So thanks, Geth. Over to you.
Yeah, thank you very much. Next slide, please. So I thought this would just be helpful, just to set in context the demand and activity that we had over the last, since 2019-20, using 19-20 as our sort of baseline pre-COVID, and you'll see that our referrals have returned back to normal, which is the top box, and our activity levels have increased in order to step back up in order to deliver the level of outpatient activity that we need. The differential between referrals and derived demand is referrals are the total number of letters and what have you we receive. Derived demand is where we have what we call a rot rate. So patients who choose to not go ahead with their outpatients, so they might decide not to go ahead, that we can manage them in a different way. And so we don't actually end up seeing the full number of referrals. In terms of follow-up demand, again, we've seen that number go back up very much to pre-COVID levels, and we've stepped up again the level of activity in follow-up. Of course, what you'll all be aware of is the backlog. So we have got a backlog of patients waiting follow-up, and that is that differential from the 614. Whilst it's climbed back up where it was lower, that's what's created that ongoing backlog. And then in terms of stage 4, which is the treatment stage, our step up, so whilst referrals have remained slightly lower, and we've stepped back up our activity, we still have a gap. And what you'll see on the next slide, please, is that nicely in graphical form. So on the left is outpatient activity, so you can see we've come back up, and we're doing the level of outpatient activity that well above actually we were doing pre-COVID, but we've not seen that step back up in terms of inpatient and day case activity. Now there's a couple of reasons for that, which if I can jump to the next slide, please. Is driven by the size of our waiting list, but a big part of the challenge has been that we made a decision as a health board during COVID to switch some of our theatre capacity. So pre-COVID we had inadequate capacity for trauma and emergency operating, and so during COVID we stepped up to make sure that we had weekly daily trauma lists on every site, including at the weekends, and additional CPOD theatres, which are emergency theatres. That has reduced with a constrained number of theatres. By switching some more to emergency, that's created that problem. What you'll see then on this graph is so we've targeted our longest waiting patients first, so our 156-week cohort has come right down. We are aiming to have that cohort cleared by August. There's one cohort of patients that is our challenge, and that's a very subspecialty group in urology for patients who are having procedures for impotence. So that is our one cohort that we're just trying to work through the final plan for. Again, we've reduced our 104-week waits, and across many of our specialties, we've now got really clear plans, as we'll come on to, in order to deliver the ministerial target of no one waiting over 104 weeks by the end of December. But you know, as you'll see, we've reduced that by over 10,000 over the last year, which is really promising. I guess the challenge for us then is the total waiting list over 52 weeks, and particularly for new outpatients is pulling that down. So if you go to the next slide for me, please. So we've taken a number of actions. We've restructured our processes. We've got much better validation. We've implemented what we call a 642 process. That is around looking at all our theatre lists at 6 weeks, 4 weeks, 2 weeks, making sure we've got staff, we've got patients booked, all the kit is booked, so that we don't lose capacity. And if there isn't a surgeon at 6 weeks, we're offering it to another specialty. So making sure that we use as much of our capacity as we can. And our theatre utilisation group, as I'll come on to, is again looking at how do we then maximise the use of those theatres on a day-by-day basis. As people will be aware, our orthopaedic arthroplasty surgery moved down from PCH to Ward 15 here as part of that ability to ring fence that capacity. It's allowed us greater flexibility, and we've centralised the breast services here on the Royal Glamorgan campus, with Snowdrop Centre opening and now for all patients, but also the opening of what was the old obstetric theatre into the RGH South Theatre, which means we've got a dedicated facility for breast cancer treatment. And we're seeing, by having that dedicated theatre, we've seen productivity improve. They're now booking at least one extra case on every operating list. Some surgeons are now doing an extra 2. So we are seeing, because we've got that ring fence facility with a team, that productivity improving, which is great. Next slide, please. We've had girth reviews across a number of specialties. So we've had them in theatres, we've had them in urology, ophthalmology, general surgery, gynecology. We are working with them then around head and neck services. And sitting around that is that there's an all Wales model now of clinical innovation networks. And they are really focusing to try and make sure there's a standardised approach to pathways across specialties within Wales. We're working very closely with UHB around redesigning our ENT service. That again is they've done some really innovative work there to address some of their capacity challenges, which we can learn from. And we've got transformation programs in pre-assessment, urology, ophthalmology, endoscopy, and we've seen the benefit of that. And we touched on earlier the conversation about the regional ophthalmology and trauma and orthopedics group. Next slide, please. There have been some constraints. So I've touched on the switch of CPOD and trauma. Strike action did have a big impact for us on some of our elective programs. We have a real challenge around WPAS for us because, of course, we still run 2 separate waiting lists. So we have a CT waiting list and a Bridgend waiting list, and that creates real complexity of being able to move patients through capacity. There are a range of digital enablers that we're working really closely with Stu and Suzanne on around those services and how we can get more effective electronic referrals and self-check-in and all of those programs. We have seen some demand increases in some specialties and particularly increase in cancer referrals. So, and because the routine waiting time is so long, we are seeing an uptick there. And our elective bed capacity is constrained with emergency pressures, so we don't always book to a full list, knowing that we don't have the bed availability to support it. So again, that does have an impact. Next slide, please. So to answer all of that, we've developed the Productivity Improvement and Transformation Programme for CTM, our PIP programme, and this is about how we're driving the improvement across our elective programme. Next slide, please. So there's a range of objectives through this programme. So it's about increased efficiency, it's about enhancing the quality of care we provide, utilising our resources far more effectively, better outcomes for patients, reducing that variability in our service model, and making sure that we are using data to drive our decision making through those services. And also then really key to this is about our workforce development to drive that improvement. Next slide, please. So this is how we've structured the PIP programme then within CTM. So we have our theatre and anaesthetic utilisation group. So this really focusing about making sure we sweat our theatre sessions really hard. Our theatres are in use for probably about 40% of the week, 60% of them they lie idle, hence the conversations in the political discourse at the moment around using them at weekends and in the evenings. So the majority of our theatres are used primarily between 8 and 6 every day. They're big, expensive capital assets that we're not fully utilising. But this is about making sure that those lists that we have got, they're all starting on time. The downtime between each case is absolutely minimised, and then we're reducing on the day cancellations. We've then got some really focused work on our outpatient model and primary care. So we've introduced a model called Healthcare Pathways. This is about really clear referral criteria, pathways for management, remote management. It comes back then to our ability to use electronic referrals. We had a great presentation yesterday about the impact of those in orthopedics being led by the physios from Zoe Brewster. And the other key focus there is shifting the vast majority of our follow-up activity to PIFU and SOS. So that's patient-initiated follow-up. So we know that there's a lack of understanding of the the patient initiated follow-up model with our clinicians. So we've changed the criteria of that, and that will allow us now to shift far more of our capacity in clinic to first new outpatient slots rather than following up patients on a 6-monthly cycle, which it has no clinical value to their outcomes. We've got a lot of work going on around improving pre-assessment and shifting that very much to a digital focus. So at the moment, we bring all our pre-operative assessment patients in for face-to-face assessment. For many of those patients, that's not required. And so we've offered ourselves up to be the pilot site for a digital solution for pre-operative assessment with NHS Wales. And again, a lot of work on how we improve our productivity in our diagnostics services, clearly in radiology, but also in cardiac diagnostics, neurophysiology, as we've touched on. And again, we've got work streams around our therapies, and particularly, how we can maximise the expertise of our therapists, and in terms of really driving that elective length of stay much lower, and learning from places like Exeter, where they've done a very different model of post-operative recovery for orthopaedic patients. And then the final cohort is then the cancer. So these are cross-cutting programs that will work everywhere. On the linear, so below that, then every specialty has got its service improvement group. So that's where we take the very specific specialty actions, either from the CINs or from the GIRFT reviews. And so every specialty has got their own plan on delivery then on that. So recognising that that's a big, an awful lot of work that's going through at that specialty level. Next slide, please. So what's the benefit of that, and what are we aiming for? So there are 3 key focuses for us. One is around effective waiting list management, and that's around a real focus on treat in turn. And so where we've got differential waits on sites or between individual surgeons, trying to flatten that unwarranted variability out. So very much looking at how we move to a proper model of treat in turn. We've touched on a lot of the modernisation of outpatients and preoperative services. And then in terms of maximising our theatre capacity, this is about making sure that we run every list. So we have made an investment as a health board to staff every theatre. So every single theatre list across all of our theatres in this health board now are staffed. What we've got to ensure is that every single one of those lists run, and that those lists run in a really productive way, and that we maximise that improvement. Now, based on the evidence from GIRFT and other sources, we believe there's an opportunity for us to increase our overall theatre productivity by about 25%. So that is the equivalent. So in orthopaedics, we normally list 3 patients on a list. That's about taking it up to 4. The GIRFT recommendations is you should be doing 4 joints on a list. On every operating list. It's about us increasing our cataracts to 8 to 10 cataracts on a list rather than the 4 to 5 that we're doing at the moment. So it is really about making sure we've got that productivity, to that tactical list booking, and really making sure that we can drive that productivity up. We do think there's a productivity opportunity in outpatients. It's probably not as great because I think we've done some of that, but we are aiming to achieve a 15% productivity uplift in outpatients over the course of this year. And again, so if we go to the next slide, please. And the next slide, I'll not talk to that one. We've set up dashboards now. So this is the theatre dashboard. So this can run for health board wide. We can cut it down to individual theatre or individual specialty. The data in it isn't validated, so please don't look at the data, because it's not right yet. But we're developing these dashboards now for every element of that programme, so that we'll be able to do that level of deep dive. Next slide, please. So at the moment, this is what our trajectories are telling us. So this is based on our core capacity and the additional schemes that we've made a decision to fund through our planned care recovery monies. So in terms of over 52-week challenges, we're left with challenges in urology, ophthalmology and cardiology. There are, we think, through that productivity improvement, we believe that we can deliver that in those 3 specialties. There is an awful lot of work to do around referral criteria, virtual management. We've had a conversation with the clinical director of cardiology this week about how to increase the volume of straight to test. Key to them having the confidence to do that is to deal with the waiting time for echocardiogram. So that's a really important piece of shifting our clinical behaviours. And then in orthopaedics, is the specialty where we think we remain with the key challenge. It's not a huge number by December. We're only talking around about 300 patients. But again, it is about how do we create enough productivity improvement in theatres to deliver an extra 10 joints a week every week through that programme. So that's where we're targeting this productivity now, is to really drive that and to ensure that we can provide that value for money. Next slide. Thank you. There are always risks. It'd be wrong not to pull them out. Our workforce, who knows about future industrial action? It is about us delivering a demand management change. And if I'm honest, it's the sheer volume of the number of programs of transformation and change we've got to deliver. Because we are spinning multiple plates now on this. The clinical buy-in and appetite, as well as the managerial support, is there for delivering the change. It is a question of sheer capacity to deliver it. But happy to finish there.
Gethin, thank you very much for the presentation. And certainly, from my perspective as chair, I would like the board to endorse this approach. I don't want us just to note the work that Gethin and the team are doing. I'd like us to give as much vocal support to Gethin as he works with the care groups and others to improve our productivity. And I think setting out the ambition to improve theatre productivity by 25% and outpatient productivity by 15%, it's the right thing for us to be doing. And I know that Gethin has challenging ongoing conversations with care groups and other staff about the importance of utilising our capacity far more effectively. But I think the message ought to come from the board as well, that we are fully behind this and will help drive this particular work, because it is important that we are more effective in using our resources to maximum effect. I think this is a great start, Gethin. I know this also builds on the work that you have been doing for some time with our teams to address this. So this is not new, and this has been part of an ongoing discussion. I'm bringing in that Paul.
Well, no, just to endorse what you just said, John. I think also just to highlight that there is a very clear expectation from government that all boards should be cited on these issues and should also be tracking the progress. So one of my points is going to be, I guess, Gethin, we've got that trajectory ambition. We just need to think about then that needs to be featuring in the performance report now every month on how we're doing against it. Because to the best of the world, you met any IM who comes into contact with the minister could be asked, where are you at on your productivity, and do you know? Because it is absolutely on her radar, and rightly so, because these are expensive resources. As Gethin said, we've got fully staffed theatres now. That costs a lot of money. And if you draw an analogy with, you wouldn't have an airline with fully staffed planes sat on the tarmac and a load of people waiting to get on them, and everyone going, "Oh, we just haven't got ourselves organised to get the people on the plane." It needs to be something that we are really focusing on. And most importantly, every one of those numbers of people is a patient waiting for their treatment, and the more we can get them through. And we've seen really great progress in things like the diagnostic pathway, the endoscopy pathway. It just shows when we put our mind to it, we can make this happen. And I think this is a real challenge to us now as an organisation to say, how do we really make some significant inroads into this? Because as Gethin said, you speak to the clinicians, surgeons generally just want to operate, and their frustration is always that they've never got the capacity to do it. We've now put the capacity in place. So now the challenge back to the specialties, right, how are you going to organise yourselves to make sure that these lists go fully utilised every time we're running a list? So I think it is a really, really important piece of work, something we need to be keeping an oversight on for this board.
Kath?
Yeah, I just wanted to link it to something Greg and I went to, which was the Don Berwick Bevins Commission, wasn't it? Sort of masterclass, which was around productivity and sort of waste.
Yeah.
And what they're appealing councils to consider is, how do we involve the staff to come up with ideas around savings where they know they're doing something that is taking a long time or is not very productive. So, but I do also appreciate as a health board, we are doing a huge amount
I think you're right.
of stuff. So it may not be the right time,
Well, no, I think
but it's kind of
this is part of that answer.
with the productivity.
This is part of this
isn't it?
answer,
Yeah.
because it cannot be right that we have theatres that are not being fully utilised, and yet in another part of the system, we're paying people WLIs to do extra lists. That is waste. And so actually, all of this work that Gethin's doing is about, you could call it eliminated waste project as much as you could call it a productivity project, because it's all about that. But it's very also being driven by the theatre staff, the surgeons and anaesthetists giving their views on how we could make our services more efficient.
Yeah, I mean, I'm totally supportive of this. I think it's the way you have to go. One question though, and I'm not quite understanding one thing, and that is we say that all the theatres are 100% staffed now. If that's the case, there are time slots are not being utilised. That's what's happening. Or do we need more staff in order to increase the flow through?
It's a little bit of everything at the moment. So it is about making sure that we're deploying the staff as flexibly as we can to cover all the lists. It's about making sure we've got the right bits of the staff model. So whilst we've now fully recruited the scrub staff and the ODPs, we've got to do some work with the job plans of our anaesthetists to make sure that we've got anaesthetic cover to every one of those lists. And then making sure that we've got the greatest amount of flexibility within our surgical job plan to make sure that there is always a flavour of surgeon available to run that list. And what we're trying to do is balance out within each specialty where and who we can get to move around, which is the 642 process. So they're meant to be going, what they're doing in that process. They're going, okay, so Theatre 3 at Princess of Wales on Wednesday is, the surgeon who's normally timetabled for that theatre is off. So is anyone able in the specialty to refill it? Yes or no? If not, right, which other specialty can we offer it to within POW? There's no availability, right? Is there a surgeon at Royal Glamorgan or Prince Charles who can then go down and cover that list? And which patients are we moving down there and how are we going to go? So it is about seeing our workforce very much as a CTM wide workforce and moving them around to make sure that we maximise the utilisation of it.
It's a complex timetable problem.
Oh, and of course you've got to make sure you've got the right kit, because actually if we're running too many orthopaedic lists, we haven't got enough power tools. Or how many laparoscopic stats do we need, or how many radiographers do we need to then cover? So it's a massive complexity of timetabling, which is why we work it on that 642 program.
I don't know. I used to have to do that for lecturers, and sometimes even worse.
Thanks, Ian. Any other questions to? Patsy, yes.
Yeah, just one quick one. 100% support with this, but how do we make sure that by increasing that productivity, we are not running the risk of not getting it right first time? Yeah. How do we ensure we don't run the risk of not getting it right? So this is all around getting it right first time, isn't it? So increase the productivity.
It's about using the evidence base, and if you take so GERT have developed a number of documents called Further Faster, which are really clear about what's the optimal model. And we've got 3 different ways of doing it on each site, and so a big part of this is saying no, there's one standardised way we'll run this service in CTM, and this is what it'll look like. And this is the expectation of compliance with it. And this is because it's evidence based, not because Mr. So-and-so retired 20 years ago, set this service up, and we just want to keep doing it that way.
In addition to that, the new PROMS platform is just about to be launched. So we'll have patient reported outcome measures, per service and PREMS. So together, it should exactly, hopefully, alleviate any anxieties we may have around productivity. Doesn't necessarily mean less quality.
Thank you. Any other comments or thoughts? Can I know it didn't come with a specific recommendation, but I looking to the board, I would like the board to endorse the approach that Gethin has put to us today. I think it's great to see progress in this way and to set that particular ambition around the theatre productivity and also the outpatient productivity improvements. So, see agreement. Thank you very much indeed. Okay, super. Thank you, Gethin. Brilliant. And I think Paul's right. We do need to include this now reporting back to board as we meet every other month in public session. Thank you. Okay. Moving on to item 7, the acute clinical services plan update. Linda.
Thanks. I'm not going to go through the slides. They're in your pack. They were the subject of a recent board development session where we brought everybody up to speed with the kind of legal requirements around service change and the fact that we need to do this systematic public engagement to create our proposals for how we take forward our develop our acute clinical services plan, including how we approach our the shift left that we talked about earlier and managing more people in a preventative and community-based fashion. The slides also then list out all of the functional needs that we have in order to deliver that systematic public engagement and a timetable. Just a couple of things to say. So clearly the fact that we now know when the general election is clears the timetable and in theory gives us the opportunity to go at this from the 5th of July all the way through till all the way through to however long it takes. In practice, we've got some work to do still around securing the capacity and the capability. Vicky and I are doing a tour of all of the directors to work through what's needed from their function to deliver on this programme and what the options are, how we redirect, because we've got a small budget for this. We talked about the next steps. The budget is enough to secure some programme management. It's not enough to do that whole engagement. So we've still got some work to do to, the money's not there. We've got to make more savings if we're going to invest in it. We've got to look at how we could achieve some of this, but I think we're equally clear, aren't we, that we can't go at this half cock. We've got to make sure we've got everything secured in a really robust fashion before we do actually go out and start this process with the public, because we can't get it wrong. So we are reviewing that part of the process and what that means for the timeline. At the same time, Gareth and Matt and I have been doing some work on reviewing our sort of governance arrangements to make sure we've got the right sort of project management and programme management arrangements in place, and reporting lines are clear. So the stuff that we're still doing, we're working on our baseline assessment of, and developing the case for change, evidence base. But I think it's fair that the board understands that we're in this slight hiatus while we try and work out how we achieve this with available resources.
Linda, thanks. I know that the slide deck has been used in board development session to update colleagues, but I'm just wondering in terms of what Linda set out around some of those really key considerations around process and requirements and timescale. Any particular questions or comments at this point? No? So,
Just one comment, and I know I've made it before, but this talks about engagement with clinicians, but it's not. I can't see that it's driven by clinicians, and I think to convince the public that what we're doing is in their best interest, which is what it has to be, it needs more clinical oomph behind it. That's just my reading of it.
So I think the clinicians absolutely are there, front and centre and driving it. I guess it's about
it's the presentation of that. That's all.
But they, for assurance, they are, and very much see their responsibility is communicating that as well.
They're very engaged in it and definitely driving.
And part of the review of the programme arrangements is to have a clinical directorship. And in fact, I know that you're on the case, aren't you?
We have just drafted the job description actually. So yes, we're going to have a assistant medical director who will be helping to drive some of this as well and coordinate.
Yeah, but I take the point about the presentation.
Yeah, I'm not suggesting.
The point, yeah, I think, that's fine. Yeah.
Thanks. Thank you, Linda. Much appreciated. Kath, just
Yeah, I think I was looking at it from the other sort of lens, I suppose, in terms of somebody who kind of lives in the area and works in the area. Is around, you know, if you're sat next to somebody in the bus or you're at book club or you're talking to the community, what is the case for change? So I know you're working on it, but there'll be a more detailed case for change, but then there'll also be in simplistic language that we all understand, that we can talk to our neighbours about when they say to you, Kath, what's going on in the health board or something, you know what I mean? So it's just a plea really to say that I think we obviously need all the detailed business cases and case for change and all the process, and I totally understand that. I think that's really great. But I think it would be really useful as well for us to have that sort of, I don't know what to call it really, a sort of a strap line in terms of what is our vision and what do you say to your next door neighbour around why you're doing this, you know, what you're doing and why you're doing it, sort of thing, would be really, really helpful to talk about those issues.
When we talk about the case for change, it isn't just the weighty tone that describes it in a lot of detail for us. It's also narrative that we then tell to our communities, and we touched on this with our community leaders network in previous meetings about how we use some of the voluntary sector groups, the third sector, the other people in our communities who can help convey some of the messaging around this. And that, as you say, Kath, we've got to give people the sort of the lines, sort of the background and the experience, and that will be part of our engagement.
And the language we use to describe that needs to not come from our understanding. It comes from the community. They'll help us translate the complex documents into things which mean something to people that can then inform those conversations on the bus or in the butchers or in the post office.
Because even the term secondary care, people on my table when we were doing CTM leaders weren't all sure what secondary care actually meant. Do you know what I mean? And I think we're getting better at it as we go along, but I think it is just that using sort of language that people understand. And
it's really underscores the need to have a team who can do this, because just getting that right requires dedicated people who've got time and skills to get and know how to get that right. And not people like us doing it in the margins of our day job.
Okay, thank you, Linda, much appreciated. Moving on to item 7.2, tackling type 2 diabetes in CTM.
Thank you very much.
Thank you very much.
Thanks, Chair. I'm not going to labour the paper. I think elements of it have already come across people's desks in various committees, etc. We're asking for the board to support this package of work. Just to give some background, diagnoses for diabetes mellitus has increased 40% between 2009 and 2022. And we have to see this in the context of 68% of our population being overweight or obese, and 8.59 being registered diabetic, as well as the wider context in terms of deprivation that's experienced in our communities. Diabetes brings with it increased health risks, increased healthcare utilisation, and of course cost as well. I often bandy around that sum around 10% of the NHS budget being taken up with diabetes. That statistic is getting quite aged now, in actual fact, and the estimate is by 2035 that's going to rise to 17% of the NHS budget, 80% of which isn't down to the diabetes itself, it's down to the complications of diabetes, right? We know that 90% of diabetes is type 2, of whom the individuals experiencing diabetes, 80% are overweight. And so there's a lot there in terms of prevention, primary prevention, secondary prevention, and tertiary prevention, right? We also, the paper talks about pre-diabetes, where the glucose level's raised, but it's not at the level of diabetes. They don't have diabetes yet. But likewise, that's associated with significant complications and health issues as well. And in December 2023, nearly 16,000 of our adult population, 3.3%, had pre-diabetes. And what we know is that we've got under ascertainment. So we are often picking those people up opportunistically when they go for other things. And so this is part of a broader package of work between Public Health Wales and a number of health boards across Wales, identifying diabetes really as the one of the principal public health issues of our time. So the type 2 diabetes priorities are preventing the risk factors for type 2 diabetes. We talked about the weight management and the healthy weight work that we're doing. Preventing the onset of diabetes amongst those who have modifiable risks and screening for it as well, so proactively seeking individuals out, and preventing poor outcomes for people with type 2 diabetes through proactive care, and obviously the annual checks. There are a number of challenges, opportunities that we talked about, I think, in length amongst this group, ranging from the development of systems wide working to help people maintain a healthy weight, through to our weight management services, awareness in our population as well, so working specifically with our population, the remission service, the treatment pathways people are on, the audit work that we're doing, improving pathways, and often as well, going back to the point about engagement, around poor patient engagement or compliance, that need for feedback mechanisms. There are key risks to this. I mean, this isn't a case of we are going to be spending money irrespective of what we do, right? And if we don't act proactively, the issue is going to get worse. It's going to cost us more in the future anyway. And that, yes, the ask really is that the board support this package of work. Clearly, a plan without a budget attached to it, and as you can see from the paper, the budget hasn't been identified for all the areas of work. It isn't a plan, it's an idea. And so we're at the early stages in terms of identifying those funding. But clearly, we have a number of next steps in this. We have a joint board session coming up later in the month. Type 2 diabetes will form the basis of the DPH report for this year. We are continuing to explore funding opportunities and to collaborate effectively, not only within Cwmtach Morgannwg between public health, community teams, secondary care, but also at a national level, so that things can be done once for Wales as well. And so, yes, I will stop there, Chair, but it's simply for the board to support the direction of the work in terms of tackling type 2 diabetes.
Thanks, Philip. And yeah, as you say in the report, you've set out quite a significant amount of work that's being done. There's no quick fix. The approach has to be multi-layered, multi-factored in a sense, because there are so many things that will make a positive contribution to how we can approach what is an increasing challenge. And there's a key range of next steps there, which are really, I think, are really quite significant. And for us, I think as a board, we ought to be saying that we are committing ourselves to flattening the curve, because, as you say, the trajectory, if you base it on the past 10 years and fast forward to 10 years from now, it's pretty woeful. And I just don't think we can sit back as an organisation and just think, oh, well, that's okay then, because it isn't. But how we get to a point at which we start to have a positive impact on people's lives alongside a whole variety of other organisations, whether in the public sector, the third sector, community-based organisations, health practitioners and others, is clearly going to be an ongoing piece of work. One of the things that does strike me is that it's in the management and the delivery of our own services. For example, could we be better at delivering community-based care and support to people who have type 2 diabetes far closer to where they live? Are we expecting people with type 2 diabetes, for example, to come to hospital appointments in some distance for many of them that could easily be done by colleagues in primary and community-based care? Is that something that will be beneficial? to our communities, to our patients? Would it be a more effective use of our resource? I know there's a lot we're discussing through the acute clinical services plan, which is not just around the makeup of our hospitals, but about those things that fit in hospital and those things that, quite frankly, would fit better away from hospital. Is type 2 diabetes one of those potentially that we could look at? Now, that's just the management of the condition, but just in terms of the role of our general practice and the supporting network of staff that we have out in the community, is there something that we could be doing there next year and beyond, for example?
And just on that point, we are doing quite a bit of work at the moment with the diabetes. Phil Evans, one of the diabetes consultants here, looking at the model of care for people with diabetes. At the moment, it's looking at type 1, but it is talking about, well, actually, to be honest with you, if you're living with diabetes at the moment, it's a long-term illness. So do you need to be bringing everyone back every 3 months, 6 months for a referral? If they're relatively stable, so part of what the conversation we're having with them is, if we could use technology and digital solutions to track people's blood sugar levels remotely, we wouldn't need to be bringing everyone in for routine appointments. You could just be bringing back people whose levels were starting to get a bit fluctuate. So I think that would deal with some of that point. But you're right, these sorts of conditions lend themselves to be managed much more actively, because primary care have a big role to play in the management of ongoing diabetes. I just want to make that, I mean, this is a really, really important piece of work. And I suppose the one thing I think, Philip, which perhaps might need, we've never cracked, and this isn't us, this is generally, I can never see a bit of economic analysis that tells me if we invest £500,000 in diabetes prevention now, it's going to save us £3 million of diabetes care in 5 years' time. And I think where we always get stuck is we end up with short-term pots of money, as so is often the case with a lot of these things, of saying, oh, well, let's just bung a bit of money into this, let's bung a bit of money into that. Really, with this agenda, as you rightly said, if we invest in some of these things now, it will save us money down the line. But and this for me feels like a real public health Wales, health economics bit of work, because I've never seen a piece of work that describes that, apart from headlines of, oh, diabetes costs the NHS this, and we know it does. So what are we going to do then? And how could, by investing £1 million in weight management, is that going to be the magic bullet that helps us flatten the curve in 3 years' time or 5 years' time? And if it is, then we need to have that conversation about that investment. But at the minute, I think we struggle when we get to talking about the budget for these things, because they're sort of things that we don't see an immediate return in year, and nor would we. But we equally don't see what the long-term efficiency opportunity is down the line.
Absolutely no, and then we have Rob has come in this last week, and we had a discussion yesterday about exactly that topic, and then could we commission potentially some of that evidence to support those decision making?
Because I honestly think if we were to tackle one big public health issue for our population CTM, it probably is obesity and therefore the link into diabetes.
Yeah.
But if we're going to go and put significant resource allocation towards it, we've got to be confident of what payback is, and also evaluate the existing things we've already got, because we have got a number of different things that we've got running at the moment.
Yeah.
And again, do we need to evaluate, are they delivering what we thought they were going to deliver? And if not, do we need to redirect some of that money? Or if they are delivering, how do we scale it and do more?
No, absolutely. And so this is about providing that critical mass. What I would appeal to members around this group, although we've asked you to obviously with the paper to support the package of work, the key thing underpinning this is that many of these funding streams are short term, that they and some of them are ending within year as well. And so from an advocacy point of view, this is the burning platform, really. And so in your interactions with Welsh Government in various roles, in various committees, it would be good to raise this and the need for continued funding and for collective effort on that Once for Wales approach, because although it is affecting Cwmtâp Morgannwg significantly, it's also affecting everywhere else.
Yeah. Okay. Yeah. Thank you for that. Ian, did you want to come back?
Yeah, just a quick question. I'm sure my brother-in-law won't mind me mentioning him, but he recently was diagnosed as being pre-diabetic. Now that diagnosis totally changed his attitude to his lifestyle. He was doing, he was having six spoons of sugar in his tea, drinking full fat Coke, and really bad lifestyle. He's lost weight and changed his life around completely as a result of that diagnosis. And my point is that if more people were diagnosed as pre-diabetic, maybe they would do the same. I don't know, everyone in psychology doesn't work the same. But what I'm getting at is people have lots of blood tests done. Do we routinely test for diabetes when that happens? Because that could pick up quite a lot of people in that process, and to me, it would cost pence, surely. Yeah. And yet they know then they were pre-diabetic, and we could give them a chance to change around their lifestyle. Just a thought.
No, it's a brilliant question.
And the opposite side of that story is my father-in-law was diagnosed with pre-diabetes, did nothing about it. He's now had both legs amputated and he's in and out of hospital, costing the NHS an absolute fortune.
Yeah. So PDHW are developing a national campaign and there is exploration of screening opportunities and corresponding evidence base as well. Clearly we can't back it up for one purpose and test it for another. But there is something about joining up the dots really.
Thanks. Richard?
Yeah, I've just to share an experience I had whilst on holidays in Forteventura, walking around, and there were just some stalls in the street, and they were doing tests, and they gave you your sugar, whatever it is, levels there and then. Mine was considerably higher than my daughter's, but she did say to me, "Oh, it's probably because you've just eaten breakfast or blah blah blah." But still, go and check it out when you get home. And they were testing everybody, tourists, residents, because quite honestly, you can't tell the difference between whether somebody is there for holiday or when they live there. There's lots of, lots of people from all over the world in Forteventura. It's very cosmopolitan, and it seemed like a really simple way of just catching stuff where people were. And I think just the point I make about everything that we've talked about today is that we've talked about the importance of going to where people are and engaging with them where they are. Yeah. But what I'm hearing is that there's really no money available to do that. And if my father uses a term about spoiling the ship for a haircut of tar, it's a very old saying. But I feel like as if we don't invest really genuinely in engagement and what that looks like and how much that costs, all of this fantastic work that Gethin's talked about and Philip has talked about and others, we could waste all of that work because we're just not doing the engagement right. And engagement isn't telling people stuff. We're telling people stuff all the time and it's clearly not working for many people in our community. So how can we do that differently? And the kind of, the market stalls in the middle of Ponty or the middle of Bridgend or up in my Steg or wherever we know there may be high levels of obesity and overweight. Let's go to where the problem is and do something quite simple that people haven't got to think about and they haven't got to make an appointment for. That would be my plea.
Yes. Thanks, Rachel. Really helpful. Philip, does that?
There's lots to go on. I mean, it's not about reducing demand, it's about managing demand. It's about taking the right services to the right people in the right place at the right time. And we know that we have under ascertainment within our patch, and that's across Wales actually, and it's across the UK. But there are people wandering around, like your father-in-law, for example, who don't know until they get really very poorly, at which point it's far harder to turn it around. But what we know is where people are given the information they need, many of them do act on it, and that's what we want for our population.
So just to ask the board are content to approve the direction of travel that Philip has set out, and that's been some of the next steps that's been included in the report. And obviously we have as you mentioned, a board development session on the 27th of June at Public Health Wales. So I think I think they take assurance from the fact that us as a health board are taking this really quite seriously and wanting to address it. So that partnership is really important, and I think that particular session again could help us just to work through some of the practical things from our perspective, but some of the things that Public Health Wales can do in partnership to help us. So Philip, thank you very much. That's really helpful.
Just one comment on the back of that, but everything else. As an ex-finance director, and Sally's too polite to say this, I'm sure, but all morning we effectively heard, we need money for dementia, we need money for diabetes, we need money. And we've also applauded the fact that we've got a lot of benefit from breaking even. So it's not necessarily just more money, it's using our money differently. And it's using it.
Yeah, absolutely.
But that 80% of 17% of our total budget by 2035, we're going to be spending that money on
Yeah.
things we shouldn't be spending.
Yeah, absolutely. Don't disagree, but I just felt it needed to say.
Thank you, Patsy. Yeah, I'm sure we would all agree with that. And yeah, Philip's point that this is avoidable.
Yeah.
Okay, moving on to item 8, the consent agenda. There are those items under 8.1 for approval. Colleagues happy to approve. Thank you. Those items under 8.2 for noting. Item 9, there's no other business. Just to ask colleagues if you can come back to me within 2 weeks in terms of any view as to how we've done in today's board meeting. Just to state for the public record, we did have a private in-committee session this morning to discuss the regional diagnostics programme update. The next meeting, a public meeting of the board, is on the 25th of July at 10 o'clock. Before I finish, I do want to place one thing on record. Colleagues may well be aware that yesterday Professor Sir Mansell Aylward passed away. Mansell was an amazing man, made a huge contribution to the life of the National Health Service in England and also here in Wales. He spent a significant period of time as Chief Medical Officer, Medical Director and Chief Scientist at the Department of Work and Pensions and the Department of Health and Social Services in Whitehall. He was the first ever chair of Public Health Wales. He made an enormous contribution to the National Health Service, was a real visionary, somebody who believed that we could be better at doing what we do and at improving health outcomes and tackling health inequalities. I know he's going to be sorely missed. He touched many lives. He worked at many different levels and was a real character in conversation. I think we are going to miss him dreadfully as a service. And whilst I know we would all want to extend our deepest sympathies to Mansell's family and his friends, I think it is a point also to, by placing it on record, to celebrate and acknowledge the enormous contribution that he made. So very sad news indeed, but one that, in reflecting on that, one that we should celebrate and thank for somebody who made such an enormous contribution. So a sad note, but also one of reflection and celebration of a man's life's work. Rydym yn dod y cyfarfod y Bwrdd Iechyd Ben, Hofyn y diogelwch sydd wedi ymuno yn ei gwylio gyfarfod heddiw. I now bring the board meeting to a close. I'd like to extend thanks to all those who participated in the meeting, or those who have observed the proceedings virtually. Thank you all very much indeed. Thank you.